What I'd like to do at the beginning today really is to answer any questions or hear your comments or reflections about the readings or about the past lecture. If there are any questions, and I'll do this at the beginning of every session in terms of anything that's come up that you'd like to raise and that we can discuss. So, I'm going to talk more about it today, but the idea was introduced by the anthropologist Mark Nichter, who at the time was working in South Asia with Brahmin women. And he talked about the idea that there were culturally prescribed ways or culturally accepted, known, common ways of expressing distress. So he used the word idiom the same way you would talk about a linguistic idiom. The idea being that if you speak English or French or Japanese really well, then you know all kinds of ways of saying things that are colloquial ways, that are idiomatic ways. They're not strictly the textbook way, they're the way that a native speaker speaks. And often those are metaphorical, often they're indirect or whatever, but they're understood by people within the same culture. Because they are idiosyncratic, because they require a lot of knowledge of language, they're often misunderstood by outsiders, and I'll talk about that today. But he listed all kinds of things. He listed complaining of fatigue and pain. He listed, in this case it was women in South Asia, people complaining of vaginal discharge and having to go to the doctor for that. Burning the family dinner accidentally was an idiom of distress. It was a way to communicate to your husband that you're pissed off. So, and the idea being that what makes it an idiom is the same way that you say something is a linguistic idiom. If you say, it can be literally a linguistic idiom, but he meant it more broadly. That's why he was calling it a cultural idiom, partly because he was tying it not strictly to language, but to culture, which is important too, because you could have within the same language community different cultures and different idioms, and you have that clearly in different subcultures or social classes or whatever where people use things differently. I'm going to talk more about it today because I think it's a very important idea, partly because not only within mental health practice does it get do these idiomatic expressions get misinterpreted, but even within cultural psychiatry, I think, and I made that argument a little bit last time when I was showing these supposed culture-bound syndromes and implying that some of these are better thought of not as syndromes but as idioms of distress. So nerves, for example, is not really a syndrome. There's so many things that could be attributed to nerves or explained as nerves or whatever. But when someone says, oh, my nerves are bothering me, we know that they're troubled by something. Doesn't mean they have an anxiety disorder or depression or any other specific thing. They may not have anything at a clinical level. It may be subclinical in terms of the intensity, but it's in everyday language. And then I use the example of depression, which has become an idiom of distress. Or another common one in Quebec is burnout, which is very popular in the past. And so again, you could try to develop a biomedical theory or a psychosomatic theory of burnout, but it doesn't function that way anyway. It functions as an everyday way of saying, I think I'm burnt out, I'm getting burnt out, whatever. Now, there may be other things going on, and there may be and again, we'll talk about it today, there may be a psychosomatic or sociosomatic or other process lying behind the idiom, but the idea of talking about an idiom is it belongs to the pragmatics of language, the pragmatics of communication, and so it's looking at how language or how other forms of communication are being used. And that's what you're classifying rather than a disorder. And the argument is that that's a more accurate way of understanding some expressions and then trying to decide what their implications are. And so, in fact, for DSM-5, we've written an introduction that explains in so many sentences what an idiom is, a cultural idiom of distress, with the idea that this is a useful conceptual tool for clinicians. Yeah, if you said, I'm interested in studying nerves, I want to know what the neurobiology of nerves is, you're probably, getting off on the wrong foot. You probably have not described a discrete entity in a way that's going to be very fruitful. But if you said, what are the pragmatics of talking about nerves in everyday life, that's actually a good, useful research topic. How do people use the language of nerves to communicate suffering? How's it understood by other people? What are the family dynamics? All those other things are interesting, including what happens if you go to the doctor and say your nerves are bothering you? Because at that point what's happening is the clinician is filtering this language of distress into certain categories. And I'm kind of anticipating my whole talk today, but that's okay. It'll just be that much clearer when we get to it. I think the answer is yes, but when you focus on a symptom, you're thinking within the semiotics of medical diagnosis. So now a symptom is a bodily event or experiential event that the person's reporting. It has a meaning vis-a-vis a diagnostic system, and that's the way that you're thinking. When you're looking at it as an idiom, you're really asking, how does this function communicatively to other people? And the implication of a cultural idiom is that it has communicative meaning and value and it's understandable within a cultural community of some kind or a local community of some kind. So this one and the same event could function both ways, but the thing is, with an idiom, you don't actually have to have the headache. I mean, an example would be, you could say to somebody, you're giving me a headache, you know, and you don't literally mean you have a headache, although the origin of that phrase was from times when people really did have headaches as a result of, you know, some, you know, troublesome person or event, but now it's just become a linguistic idiom. And as I say, the slide between linguistic and cultural idiom really is just one of emphasis, since language and culture are usually very close, but you know, they don't have to be, in the sense that you can appear to be using the same language but be using it differently because you come from different cultures. Or vice versa. You can, I mean, we live within one culture with two languages here to some degree, or, you know, overlapping cultures anyway. So you have people who will use two different languages but maybe using this similar cultural frame at that moment. Yes, yeah. And again, I'm going to talk about that today. You guys are, it's perfect. We're obviously totally in sync because I don't have to do a structured lecture. I'll just respond to you and we'll work our way through everything. But that is the topic today, is about bodily expressions of stress. There's actually a lovely art history book called Gestures of Despair that talks about medieval art and the ways in which the body is shown expressing distress, with the idea that, and again we'll argue this today, that there are universal elements to this, but then there are culturally particular elements. So we can see commonalities. You can meet people from all over the world and you can pretty much tell if they're in pain or not, or possibly anyway. You can't tell for sure, but you know. But then there are other things that you might find very misleading, and I'll say more about that. Was there anybody? I think there was one other. No, that's about it. Okay. Yep. Okay. They're for it. No, no. As I mentioned, it's a complicated issue, partly because, on the one hand, the whole thrust of psychiatric nosology is to have some kind of generalizable knowledge that hopefully is based on scientific research that applies to human beings everywhere, certainly to all the different varieties of human beings found within the borders of the United States. I mean, that's their mandate, and that is a fair slice of people from everywhere, since people have come there. So that's the aspiration. There's also the assumption that many people make, that we've begun to challenge in the introductory lecture, and we'll continue throughout this course, that mental disorders reflect processes that are universal in people everywhere. And that's partly true. I think that is the case, and we'll try to show how, but it's not 100% true, that there are variations in those processes. But I would say that within mainstream psychiatry, that's not widely accepted. The assumption within mainstream psychiatry, both within the American Psychiatric Association and internationally, is that the underlying mechanisms of psychiatric disorders are universal, that they are biological, and that implies that they're universal. And maybe I made the point last time, but it's worth reinforcing again now, that the fact that something might have a biological basis does not prove that it's universal, because there's biological variation in human populations. And oftentimes when the WHO describes cross-national epidemiological study, the type that we mentioned last time, they'll comment somewhere in the text, you know, we found roughly the same prevalence everywhere. If that's the case, it's very odd, because there's almost no disease. You could look at tuberculosis or malaria or different kinds of cancer. None of them are evenly distributed across the human population, largely for biological reasons, because there's genetic variation in populations, because there's environmental variation in exposure to vectors, because there are actually variations in the nature of the bacteria and the virus that are dominant in different sort of ecosystems around the world. So there's every reason to think that biology is also a source of variation. The flip side, that there's sort of built into this duality of you know, culture, nature, or biology and culture, is that somehow culture is going to be always unique and local. But in fact, all cultures deal with similar existential predicaments, similar facts about the body. We're all born, we all grow old and get sick and die. I mean, these are the part of the noble truths of Buddhism, but they're existential realities. And so every culture is dealing with that. Every culture is developing some kind of set of ideas about that. In fact, you could argue that's a big part of the motive force behind religious systems, is to deal with those deep existential problems of human existence. So you could also say that culture is a source of universality, not just of particularity. So all this is an argument for saying that both things should be put together. So to come back to your question, though, as to the stance of the American Psychiatric Association toward this, on the one hand, there's this theoretical, implicit or explicit theoretical stance that if we know the biology, if we know the underlying mechanisms, then we have universal knowledge, so we don't have to worry too much about culture beyond being able to communicate with people. On the other hand, there's the political recognition that you have a diverse society in the United States, which is, again, the constituency of the APA. And as I mentioned last time, because you also have a lot of diversity within the profession itself now, there is a push from within the profession to say we really should be paying more attention to culture and to language and so on. And that's come primarily, the largest segment in terms of this diversity within the US are Hispanic psychiatrists, but there's also a significant number of Asian American psychiatrists and other groups, and so they have pushed for some attention to these issues. For DSM-4, there was an external committee funded by the NIMH called the Culture and Diagnosis Work Group that did a lot of work on culture, and then that was given to the work groups who had the formal responsibility from within the American Psychiatric Association to develop cultural issues. For DSM-5, there is no such process. There is a work group on gender and cultural issues, which is a small work group that has involved a larger number of people outside the immediate work groups for DSM-5 in looking at cultural issues. And those people who are involved, and it's true actually for all of the DSM, that there are people involved from all over the world, not just from the United States. And in the case of the cultural work, there are people involved from the UK, from some European countries, from India, and from a number of places. So there's a bit of input from different places, reflecting the fact, as I mentioned last time, that even though DSM-5 is officially an American or US nosology, it has important functions globally, and people want to respect that and support that by paying attention to culture. So I hope I'm giving you a bit of the notion that on the one hand, theoretically, many people would see no strong reason to worry too much about culture and a lot of the core structure of the nosology, that it would be viewed mostly as just a problem of applicability, communication. But politically, there is more recognition and acknowledgement of the importance of addressing culture. So that's kind of where we're at right now with DSM-5. And we'll see what actually happens because there's a lot of apparent openness on the part of David Kupfer and other people involved at the top, the administration, the construction, the editing of the DSM-5. But we don't know what will finally come out in the wash because there's a lot of competing forces. Please. Well, again, I think that'll come out throughout the whole course because in a way we'll be talking about different kinds of distress. So I think let's reserve that for the moment. In using a word like distress, we're trying to find a word within English that covers a very broad terrain. Precisely because we want to talk about physical pain, emotional pain, anxiety, nausea, worry, too many thoughts, all kinds of things that people might find troubling. And it's an interesting question, and again, it'll be one of the topics for today and throughout the course. Is there a general phenomenology of distress? Is there a shared element across things, or are there many different kinds of experiences? If there are, how much are those experiences rooted in the body and bodily physiology? How much are they a function of the way we think and the way we relate to other people? So that's a good segue then into the talk today, because I'm really, all the things that we're talking about are things that you're going to hear echoed in what I wanted to present to you today. So the focus today is on somatization and idioms of distress. And in talking about somatization, we're talking about the body, about bodily expressions of distress. And interestingly, this has been at the center of interest in cultural issues from the beginning. I mentioned last time that cultural psychiatry at McGill began with the work of Eric Whitcower, who was a psychosomaticist. He was interested in psychosomatic medicine. And for a long time, there's been a kind of conjunction between people interested in psychosomatics and people interested in cross-cultural work. And there are reasons for that that will become clear as we go along, so those two things have a close history. This is what I'm going to cover today. I'm going to talk, first of all, about the concept of somatization, then about the problems of dualism in medicine. I'll talk about specific forms of somatization in clinical care. Then something about the semiotics of bodily symptoms, that is the medical semiotics, how we treat certain experiences as symptoms and signs of illness and what that means in terms of diagnosis and so on. And then more broadly about this idea of cultural idioms. And then the invisible bullet points that I forgot to put on the slide because I was distracted earlier today. We'll be talking about the nature of embodiment. And the whole question of how experience is expressed in and through the body, and then how those experiences of embodiment are grounded both in bodily processes but also in social processes. And that really is the central interest in recent years in a lot of medical anthropology, and at least experience near medical anthropology. And then we'll end with talking a bit about the larger, again, social processes that those things are embedded in. So just a few words about somatization as a concept. This is a word, you can see from its form, that already implies a kind of a process of making something bodily. Something is being somatized, it's being made of the body, and that raises the question, well, what is it that is not of the body? I mean, what is it that's not somatic that's being made somatic? So you get a hint already that behind this word is a dualistic ontology. Behind this word is the notion that there could be something that is not somatic that is now going to be somatized and made somatic. And historically what that was a psychological distress, emotional distress. And the term somatization was introduced in the 1920s by psychoanalysts, arguing that there were certain kinds of psychological suffering and distress that could be translated into bodily symptoms. And so there was a whole question then of, well, what's the mechanism of that translation? And this struggle to make up kind of psychosomatic theory that would explain how things go from the psyche to the body went on for 50, 60 years or more. In some ways it's still with us. In the late 50s there was a book by Deutsch called The Mysterious Leap from the Mind to the Body, which really captures in a phrase, I think, this whole dilemma of mind-body dualism, that not only do we have to get from mind to body, but it's a great mystery as to how we could ever get from mind to body because of the underlying ontology. What I mean by ontology is a notion of what is out there in the world, what kinds of entities and things are out there in the world, and we inherit a long tradition in the West of the idea that there is mind that is somehow disembodied, and there is body that is very physical and very present as a material substance. Not only do you have that dualistic ontology, but you also, as I mentioned last time, have a long tradition of a notion that the mind and mental phenomena, mental expressions of distress, psychological expressions of distress, are more developmentally mature, advanced, sophisticated, whereas bodily expressions are more immature. There's a paper from the 40s by Jürgen Reusch called The Infantile Personality, in which he's arguing, I think that's anyway, it has infantile in the title, and it's talking about psychosomatic process, implying that it's a kind of very early developmental process to express your suffering in physical terms, as the infant cries and shakes and holds the breath, turning red in the face and so on. This is like a childish way of expressing distress. So this is built into the whole thing, and it's kind of ironic. Years ago, David Goldberg, a British social psychiatrist, wrote a lovely little paper in which he talked about talking to a Tibetan Lama and describing this idea of somatization, and the Lama said, that's a very interesting idea. That could be very useful. If you're having a lot of mental confusion and it's interfering with your meditation, you could just take all of that confusion and put it in a pain in your foot, and then you could get back to your meditation. So that completely turned the idea of somatization kind of upside down. Instead of saying this is a primitive defense mechanism or something, it implies that actually this could be a useful way to contain suffering in some ways. And I think it makes it an open question, at least conceptually, what the status should be. The whole area of bodily expressions of distress that are attributed to emotions is very important in general health care. Because, in part, as you'll see in a few moments, a lot of symptoms in medical care, a lot of people's complaints don't have a clear biological explanation in terms of a biological disease. And so psychosocial explanations are always available. You can always say, well, you're under a lot of stress, so that's why you have headaches. Okay. And therefore, we know who to refer you to or who should take care of you. So this dualism of thinking about different kinds of problems is mapped onto a kind of segmentation of the healthcare system, that there are people who are responsible for different kinds of problems. And if you come into the emergency room, they try to decide very quickly, do you go to the emergentologist or the specialist in internal medicine or physical medicine, or do you go to see the psychiatrist or psychologist? Again, there's a geographical, a spatial duality that reflects the conceptual duality that we're talking about. Nevertheless, we think that these things are related in certain ways, and the question is, how are they related? And one kind of theory of how things are related is this family of ideas of psychosomatic processes, that somehow the thoughts and the feelings we have are expressed or have an influence on bodily processes. And psychosomatic theory traditionally has been an attempt to build causal theories. That is to say, if you have a lot of stress and you're having trouble coping with it, you get physically ill. And maybe we could eventually trace all the links in the pathway, and we would have a neat causal explanation of how you go from feeling overwhelmed by certain events and feeling miserable to ending up with an ulcer or high blood pressure or some other problem. So that's psychosomatics. Competing, not competing, a complementary idea really is the notion of sociosomatics, the idea that there are social events, social processes that are affecting your body and your experience, and things could be impact that way without focusing on the psychological mediation. And I'll explain that later and how that's quite common across many cultures. Most cultures, in fact, recognize sociosomatic processes. Not every culture recognizes psychosomatic processes, but virtually every culture we know recognizes a kind of sociosomatic process. That is to say, how you feel in your body and whether you get sick has a lot to do with the social world that you're living in. That's pretty widely recognized. As somatization as the concept developed, particularly in the 60s and onward, first with the work of Zbigniew Lepofsky and then a lot of other people working in consultation liaison psychiatry, people working in general hospitals trying to provide consultation to patients being seen in medicine. There was a shift that occurred in how the term somatization was being used, so that it had less to do with psychosomatic causation and more to do with illness behavior, that is to say, how people are acting. So the issue now was not what caused your pain, but really what is causing you to complain. Whether or not you have pain, what is causing you to feel such distress and come for help and so on. So that is, again, a complementary question. It's not precisely the same question, because it actually puts aside the question of whether you have pain or not in some measurable way, whether there are certain causes for it, and simply asks, what is making you distressed? Why are you coming for help? And why is that help either making you feel better or not? So that's a kind of a shift. And I'm going to, come back to this in some detail in a moment. So let me just come back over this notion of dualism, and you've probably encountered this idea before that Western medicine, Western psychology, in fact, the Western concept of the person is typically described as dualistic, that we have mind and body, and these are separate things in some way. This is often blamed on René Descartes, which is not entirely fair. It has an older history than Descartes, and I think Descartes occurred at a particular moment in history when he was concerned to carve out a space for science while not offending religious sensibilities, and so he articulated a way to do that and to go forward. But as I say, it has a much older provenance, this idea of this dualism. In fact, you can trace elements of it back to Greek medicine, where you had a dualism or often a trialism. You had three levels. You had sort of spirit, soul, and body. in sort of different models that existed thousands of years ago. So various ideas of dualism, in fact, are quite universal. You can go around the world and you can find elements of what we're calling mind-body dualism in most cultures. First of all, because there are some fundamental tendencies in human beings toward dualistic thinking. The anthropologist is it Needham? I guess it's Needham. It's Needham, wrote about this kind of dualistic classification. And there's a famous book about left and right, and the fact that in virtually, again, many, many different religious and mythological systems deal with these polarities of left and right. And it's an interesting question to ask, is that polarity of left and right, to what extent is that a biological polarity? Because again, we have hemispheric laterality in the brain. To what extent is it a mythological construction based on just making polarities of other kinds, of good and bad, of light and dark, and so on? But those are ubiquitous. And then existentially, I think people everywhere come to see a difference between the finiteness of the body, in the sense that we get injured, we have a sort of a progression of deterioration over the lifespan in terms of our physical mobility, for example. But in our minds, we can be very mobile, and we can move about a great deal. So there's a kind of a duality there between the material and the imaginary in some ways, although not always conceptualized in precisely those terms, and that is going to be expressed in different kinds of dualisms. So even if those kind of existential things are you can find traces of them in very, very diverse traditions, the specific forms of dualism that we have in what I'm calling the West, for want of a better term right now, meaning Europe and North America primarily, in those traditions, Northern European traditions, has taken particular forms within biomedicine. And there are three ways in which it's important. I've already mentioned one, which is this ontological distinction between mind and body, and that carries over, that ontological distinction, into everyday life, because people think that there are real illnesses in which you can see something in the body or on an x-ray, or you're bleeding, and there are imaginary illnesses in which you complain but nothing can be found. And there's a Yiddish expression, which my pronunciation is not good at all, but it's an eingereihte Krank is Ärger von einem Emisser, which means an illness you've talked yourself into is worse than a real one. This is the Woody Allen phenomenon, that suffering around an imaginary illness has potentially no resolution, because it's just feeding on itself, and it has no validation from other people, because again, you don't have the visible sign. So there is an ontology here, even among people who, in their broad conceptualization, abstractly at least, would say, well, it's all one thing, isn't it? I mean, it's all one world and it's all tied together. And I mentioned last time the study that Mark Moresco did with psychiatrists and psychologists here at McGill, showing that people made these kinds of dualistic distinctions between illnesses they saw as more biologically based and illnesses they saw as more psychologically based, even within the range of psychiatric disorders. So that ontology is still present. The second level, or second aspect of this dualism, is an epistemological dualism. And they're closely linked in the sense that there's knowledge that we get by hard observation, in fact. And this, Foucault writes about this in The Birth of the Clinic, about the emergence of the clinico-anatomical pathological method. The idea that the way you can find out what a person really had is you do an autopsy. They come and they tell you they have headaches, but you don't know what to make of it. But later they die, and you can look inside and say, yes, look, they had this big thing in their head. That's what caused the headaches. I should say that's a very rare, exceptionally rare cause of headaches, just in case anybody gets alarmed. But anyway. So there was then the emergence of the idea that this kind of clear observation of something gives us real facts. The other thing, reports of suffering, are more doubtful, more uncertain, more ambiguous. They're epistemologically on shakier ground in some ways. So there's another kind of dualism between objective and subjective, if you will. Within medical semiotics, you have a distinction between symptoms and signs. Symptoms are things people report. Signs are things you can observe, and that ideally are hard for people to fake or to perform for you, so they cut through that. So for example, as we'll talk about today a little bit about conversion symptoms, if somebody his arm is paralyzed and you're trying to figure out, is it a neurological problem or is it a cognitive psychological problem, then one of the tests you may have is you take their hand and you drop it over their face. And if it misses their face, you think, aha, you see, they say they can't control it, but they're artfully making sure it doesn't hit them in the face. Of course, if they do hit themselves in the face and get bruised, you have a problem. You think that now maybe it is more real and definite, and it may or may not be, and vice versa for that matter. And I'll show a film today. I'm going to show you a different film than we had originally planned, but one that really illustrates this very dramatically. There's a final dimension to this dualism, and I think it's important recognizing that there are these different kinds of dualism, because even if we solve one, or even if we find a conceptual scheme that brings one together, it doesn't address all the other elements. And this third dimension, again, they're interwoven, the third dimension is a moral dualism between things that happen to you, accidents, illnesses that you're not responsible for, and things that you do to yourself. And again, you see this dualism all the time in medicine. People are trying to decide, should we feel sorry for this person and give them care because it's just an accident, they got cancer, what could they do? Versus, oh, they're alcoholic, they're really kind of doing it to themselves, aren't they? And so it's in that context that the efforts to medicalize problems and to biologize them is trying to struggle primarily with this moral dualism and this kind of distinction between things people are responsible for, things they're not responsible for. And that's also why, even after you solve some of the other problems, these things come back, and why so much is at stake for people. It's not just an abstract conceptual problem, how do we put together all these different levels? It's a big issue of how are you going to be treated in everyday life, and are you going to be held responsible for your problems? Okay, so it's in this context of these ontological, epistemological, and moral distinctions that the categories of somatization and somatoform disorders, which is the group of problems of somatization, that's the name for it, somatoform, which again, the shape of that word, the grammatical structure of that word tells you something. It's saying that these are problems that look like they're problems of the body. They're in the shape of a bodily problem, but the fact that they're in a psychiatric nosology implies, oh, but they're somehow a psychiatric problem. And because we're in a dualistic system, the fact that something is a psychiatric problem implies it's not totally of the body, that it must involve the mind, whatever that is, higher order processes in the brain, if you want. So this is another nice, we began with an image for William Blake of loss suspended over the abyss. And this is another Blakean image of Adam and Eve in the garden. And this represents, again, this moral dualism of struggles over desire and so on that get layered onto our notions of illness. So I became interested in this area not originally through cultural issues, but because I was working as a consultation liaison psychiatrist in a general hospital. So I was being asked to see people who had pain that couldn't be explained, or who were very worried about illness even though they'd been told there was nothing wrong, and a whole range of problems like this. Then I began reading the cultural literature and discovered that there was a significant literature talking about somatization and arguing that people elsewhere in the world, non-Westerners, that is to say everybody outside this little group that described itself as Westerners, that other people, meaning Asians, Africans, and so on, were more likely to somatize, to express distress in bodily terms. And I was struck by the notion that what could not be quite true, because in my everyday work in the General Hospital here in Montreal, there were lots of people who had somatic complaints. And in fact, when you look at the early studies making this argument, comparing, saying that, say, Chinese are more likely to somatize, an early paper by Arthur Kleinman, very important figure in cultural psychiatry and working in Taiwan, where he wrote a paper called Depression, Somatization, and the New Transcultural Psychiatry or Cross-Cultural Psychiatry. The comparison that was being made was between people in primary care or in traditional healing settings in Taiwan and people coming to the Harvard medical system in Boston and to the Massachusetts Mental Health Care Center. So I mean, that was the implicit comparison, because he was just looking at a group of people, you know, in the ethnographic work that he was doing in China, but in the back of his mind, the back of everybody's mind, were the different clinics that they were working in that were in these highly specialized, differentiated healthcare systems. So it occurred to me that this is not a fair comparison. And I think we have to make a better comparison. So we, with a colleague, Jim Robbins, a medical sociologist, we decided to study somatization in primary care at hospitals in Montreal. And I'll show you some of the results from that. But the first problem we had was how to operationalize the definition of somatization. Because if you say what somatization is problems that are really emotional that are being expressed bodily, you have a very abstract idea. And the question is, well, how do you know? And there was, at that time, a whole literature on things like mask depression. The idea that somebody could be smiling, say they're not depressed at all, and all they're complaining about is headaches, but they really have depression. And again, this struck us as a very confusing and you know, hard to substantiate claim. I mean, who decides that this is really depression? What is it you're looking for? If there's no independent measure of depression, then it's just a theoretical model imposing itself on something that could be interpreted different ways. So this was the challenge. And so we came up with these three very simple definitions based on what was already going on in the literature. It's really just a redescription of what was there, but that could be operationalized. And the first was people who have an identifiable psychiatric disorder like major depression or panic disorder. It's not hidden. You can ask all the questions and you'll make the diagnosis. But all that they're talking about to the doctor is that they have physical complaints. So if you take them aside and interview them, you can diagnose depression. But in terms of what they come to the doctor with, they're just saying, I'm fatigued, I have headaches. That's all they want to talk about. So that is a style of clinical presentation, if you will. The second area is people who, whether or not they have a lot of physical symptoms, are very, very anxious that they have a physical health problem. They're convinced there's something wrong with my brain. I think I have cancer. I think I have a heart attack. So they're really persistent, and this includes hypochondriasis and all kinds of other health worries. And the third notion that we found in these discussions of somatization was people who have what you could conservatively, parsimoniously, and purely descriptively call medically unexplained symptoms. That is, they have a symptom for which nobody can find a good explanation. And as I said, once you have that, it's very easy to come up with a stress or psychological explanation. Everybody has stress. It's not hard to sort of find something to pin it on, and that's another category, if you will. Please. Yeah, so you're raising the example of fibromyalgia, which, in fact, during the course of the time that we did this research, went from being something that people viewed as a non-entity to being of great interest. Initially, it was called fibrositis, which implied inflammation. itis, itis implies inflammation. So then people did all these studies taking tissue samples looking for inflammation. They didn't find anything, so that was a big problem. And then so they changed the name to fibromyalgia, which implies connective tissue and muscle pain, which is, again, purely descriptive title. But then people decided, oh, we can operationalize the diagnosis of fibromyalgia. We'll look for people who have generalized pain in 4 quadrants of the body and who have tender points, where if you press them really hard, they jump. They feel a lot of pain. And if you have a bunch of these pressure points, you have fibromyalgia. And then people said, well, this is a disorder of pain perception, and it sort of got elevated from the zone of ambiguity and uncertainty and contestation into a formal diagnosis, which was important for people in rheumatology, because probably the single most common diagnosis in rheumatology is people with fibromyalgia. And it can coexist with other things, with rheumatoid arthritis, with osteoarthritis, and so on, but it is extremely common. I'll come back to that because it's an interesting example and something that we did a little bit of work on, and it's an important example for the things that we're thinking about. But it does raise one point, which is what is considered medically unexplained is also an issue of cultural fashion in the state of medical science. So as we learn more and more things, certain things go from being medically unexplained to being explained. But at any given point, even with the amount of knowledge we have, it's also an issue of sort of our own charity. Do we want to say that, okay, it's pain due to tension in muscles? Fair enough, you're too tense, so you've got pain. That's sort of an explanation. The reality is we can't measure that very well. We think a lot of back pain is due to things like that, or due to very subtle, biomechanical things, but we mostly can't measure them at all. So it's just, do you want to credit people with that, or do you want to say, no, there's no good explanation at all? When you do that, when you say there's no good explanation at all, of course you create a real quandary. Because if there's no good explanation at all, and yet this person is saying, I'm in terrible pain, either you disbelieve them, or at the very least, they represent a great challenge to your own competence, because you can't give them a satisfactory explanation. You don't know what to do next and whatever. So that's the point to be made about this last category is it's ambiguously defined, or not so ambiguously, but it's a descriptive category of a certain kind of social or medical predicament, one for the clinician as well as for the patient. So the other term the term we originally proposed for talking about these kinds of problems was functional somatic syndromes. And that implies something a little bit different, because the term functional in medicine has tended to mean a disturbance of function. And in some ways within psychiatry, there was a distinction between functional and organic. Organic meaning there is something biologically wrong that you can see, so it's a gross biological, an anatomical or other kind of deficiency that you can measure. Whereas functional disturbances, the presumption was you can't see anything. Presumably it's some disturbance in the functioning of a system without there being a gross structural lesion. Of course, because that dichotomy was used in exactly the kind of situations we're talking about, it also took on a pejorative meaning. So to call something functional, if you're a neurologist, to call something functional is to kind of dismiss it, to say it's not really a neurological disease. We'll get the psychiatrist to see this person. Something funny is going on here that so we took those three definitions, which we were able to use more or less, operationalize in a way, and we went into a family medicine clinic and we interviewed 600 people, 700 people coming to see the doctor on a self-initiated visit before they saw the doctor. And we asked them, what are you coming to see the doctor about today? Tell me about your symptoms. What do you think your symptoms are due to? Could nerves or worries have anything to do with your symptoms? And so on. So what we found, first of all, was that these three definitions were largely non-overlapping. So even though when you went to the medical literature, the psychiatric literature describing somatizing patients, they tended to put all these things together. So the people at the middle of this Venn diagram were the ones that people were typically describing. They're depressed and they're complaining of a lot of physical symptoms and they're very anxious, there's something wrong, and all these bits were together. In reality, we found there are lots of people in each of these categories, but most of them only have one or other of these processes. So that's interesting in its own right, because it means, okay, maybe we need to think about different processes for these things. Maybe there's somewhat different things going on. Yeah. No, they existed in the literature, but people were not clear in making these distinctions. As I say, most people would talk about, there are three circles there, right? And you can see that they're overlapping in different ways. And so most of the literature was on that central group. But people would not frame it that way. They would just say, I'm talking about somatizing patients, and then they would tell their story about somatizing patients. So what we tried to do, this is a paper we wrote some years ago called 3 Forms of Somatization in Primary Care, where we tried to say, look, just for the sake of clarity, let's try to tease these apart. It's an empirical question whether this describes one thing or not. And we provided some evidence that the areas outside the overlap represented at least 50% of each of these categories. 40 to 50% of each of these categories. So that was a suggestion that maybe they're separate processes going on. And yes, there are worst case scenarios, since they're all common anyway. There certainly are people who have all three things going on, and they're the ones who are having the hardest time, and they're the ones that end up being the typical patient with somatization, as it were. So I'm going to tell you a little bit more about each of these, because, as I say, this is the way we sort of proceeded. And I'm talking to you about this now in the context of general medical care here in Canada. Perhaps it doesn't look very cultural to you yet, but I'm going to show you how, well, first of all, the argument I made last time was everything's cultural anyway, so it's fine to study whatever you want. But I'm going to try to show you how this way of sort of dissecting these concepts gives us a useful tool for starting to think about cultural variations in a way. So the first category is, I'm going to talk about people who have an identifiable psychiatric disorder, primarily depression or anxiety disorders, which are the most common disorders in primary care and in the general population, who present clinically only with physical symptoms. And why they present only with physical symptoms is complex, but the most basic reason simply is that if you are very depressed or you are very anxious, you have a lot of physical symptoms. It is in the nature of depression and anxiety that you have physical symptoms. I mean, you can argue it's in the nature of the human condition that you have physical symptoms, but they are more when you're anxious. When you're anxious, you have lots of adrenaline circulating, you feel shaky, you may feel palpitations, you have all kinds of things that come with the physiology of anxiety. When you are depressed, you have increased muscle tension, you have slowed gut motility, you have a lot of things, and 90 to 100% of people with severe depression have physical pain of some kind. So that just seems to be part of whatever these syndromes are, part of whatever the underlying biology of these syndromes are, they give rise to symptoms. So on the one hand, we'd say, so it's no mystery that somebody who is very depressed or very anxious has physical symptoms. What's interesting is that even though they also have potentially emotional, cognitive, other kinds of symptoms, some people only talk about the physical symptoms to the doctor. Or if they talk about the other symptoms, they attribute the emotional symptoms to the physical problem rather than vice versa, let's say. These are some of the symptoms that are commonly associated with depression. Some of these symptoms, like weight loss, as I already mentioned, constipation, and so on, are viewed as vegetative symptoms of depression. That is to say, again, they're core symptoms of a severe depression in which there's some physiological dysregulation. And in fact, they're even used as diagnostic criteria for major depression, that this is part of what tells you this is a serious endogenous or melancholic kind of depression. So what we did in our study was we asked people, what are you coming to the doctor for? We got all that information. We asked, they gave us the symptoms or whatever other reason they were coming. For most people, it was a symptom of some kind. And then we said, what do you think is causing your fatigue, or what do you think is causing your headaches? And then if they had not brought up anything psychosocial at all, we said, do you think nerves or worries could have anything to do with causing your headache or your fatigue? So and then what we did was we did a separate part of the interview where we used the diagnostic interview schedule, which I mentioned last time, a structured diagnostic interview for making, in this case, DSM-3 diagnoses. And we looked for major depression, panic disorder, generalized anxiety disorder, a variety of other things. So when we do that, in our case, about 10% of the people coming to family doctors have major depression or an anxiety disorder. And that's a common figure. I mean, it varies in different samples and different settings, but it's often 5 to 15% or so. It's a fair number of people in primary care who have depression or something else. Of those people, however, 85% of them did not report a psychosocial symptom as the reason for coming to the doctor. So most of those people did not say, I'm coming because I'm depressed, I'm coming because I'm anxious. Most of them said fatigue, pain, or some kind of musculoskeletal pain. Those are the most common reasons for coming to the doctor. And that cut across different levels of education, different cultural backgrounds. So it was a very diverse group. This was done here in Montreal at two of the McGill teaching hospitals in the Côte-de-Neige area. When we asked people, and so 15% of the people here on this diagram, the pie chart, are listed as psychosocial presentations. So that was we classified anything that was vaguely psychological or social, like, oh, I'm coming because I'm under a lot of stress. Okay, fair enough, that's psychosocial. Or I'm depressed, or I'm having trouble at work, or anything like that. So, but only 15% of the people with depression and anxiety disorders presented that way. When we said, what do you think is causing your problem, 34% of people said, I think it might be because I'm under a lot of stress. So of those people who said, no, but I have headaches, a significant chunk then said, okay, but it's because of stress, because of something emotional. So those people we called initial somatizers. And they're showing what in the family medicine literature at the time was called ticket behavior. That is, if you want to go to the doctor, the appropriate thing to have to tell your employer, your teacher, or your family, or the doctor themselves is, I have a physical symptom. So you may well know there are other things going on, but this is the appropriate way to go. But there was no, even though it looks like somatization, there was no difficulty in getting people to immediately make the connection. Okay. But then that still left half those people. So of those remaining half, when we said to them, do you think nerves or worries could have anything to do with causing your problem? Half of those people, again, 25% of the initial sample, said, yes, I think it has something to do with my problem. So those are facultative somatizers. That is to say, if they're given the alternative explanation, they're willing to work with it. And then finally, we had a group of people who persisted in saying, no, it has nothing to do with it, even though the way we diagnose depression was not through some kind of mysterious process. In the diagnostic interview schedule, it asks, have you been feeling sad or depressed? And so these people said yes. Or have you been feeling suicidal, and have you been crying a lot? So they said enough of those questions that they had significant depression when you asked them point blank, but they did not see them as being connected to their presenting complaints. Now, it's possible that the reason was the complaint was totally unrelated, but we went back and looked very specifically at all these things, and the complaints were primarily fatigue and pain. So things that very plausibly could be related to their depression, but which they did not connect. So this is important, and this is important that this is the case for people across the board. This has been replicated in other places, in Spain and other places, so we know that, that this applies quite broadly in other settings. And it's also important in terms of the consequences, because these were the rates of recognition of depression by the family doctors. So depending on how you present, the doctor would either say, okay, this is a depression, or in the case of the people who persistently didn't make any connection, very few of them, less than around a fifth of them, ever over a year following the initial presentation, ever got diagnosed as having depression or anxiety. So there's something going on here in the negotiation between the patient and the doctor as to what is the problem that is very heavily influenced by people's style of presentation. Please. By both, yeah, I agree. I think it's by both. On the part of the patient, one of the things we looked at, in this study we didn't look too much at stigma. We looked at some other things. One of the core things we looked at was attributional style. That is, if you have a headache, what would you think it was due to? And that does predict this style of presentation. People who make psychosomatic explanations all the time are more likely to report a psychological link to their symptom. People who think that physical symptoms are a sign of physical illness only are more likely to persistently present this way. So that's one component. We know that we also ask people about help seeking. Would you go for help? And we ask them about physical illness and psychological illness. So again, people who would go for help for psychological illness are less likely to somatize in this sense. Those who would not are more likely. And we know from other studies, for example, a study by Raghuram and colleagues in India, where they argue and try to show indirectly at least that somatic illness is much less stigmatized than psychological distress, and so therefore this is following a pathway that is safer for people, and that is going to get them help, but not at the risk of having labeled themselves as having a personal problem or a stigmatized problem. So that's undoubtedly part of what's going on. And as you said, it's also an issue on the part of the clinician, because clinicians are reluctant to make psychiatric diagnoses, or were at this time. This is 20 years ago or more now, and one of the issues at that time was the antidepressants that we used in medication were difficult to get people to take because they had a lot of side effects, and so it was a real pressure on the doctor to kind of work with that. And so it was, in a way, just nice to collude with the patient and say, fine, this is not depression or whatever, you don't even think like that, and we'll just go along the path. We'll do some more investigations. We'll look into this. Yeah. We haven't done a similar study in recent years. There are some similar studies fairly recently, and they find not a huge difference, including the rate of recognition of depression is still not as high as you might expect it or want it to be. And that has, again, to do with other things about the doctor-patient interaction we can talk about further as we go along. I'll leave it at that for the moment. I think things have changed with the SSRI antidepressants that are much easier to prescribe. There's been an argument that they are overprescribed at this point, and that it's just very easy for a family doctor to sort of write a prescription for one pill a day that doesn't have that many side effects, and that these are being overutilized. That may be the case. One other point I wanted to make about this is we did a one-year follow-up, as I mentioned. That's part of how we looked at this issue of recognition, but we could also look at how are people doing a year later. And one of the findings out of this is that the persistent somatizers, the true somatizers I'm calling them here, actually did not do worse than the other people. So what this raises is the trade-off that exists, and this may also be related to stigmatization. If you acknowledge you have depression, you get treatment, but you also now have to live with that stigmatized condition and that view of yourself as having this problem. And since we know that, first of all, that a lot of depression is self-limited, mild to moderate depression will get better, even severe depressions get better on their own to some degree. And we know that the antidepressant medications are not as good as we thought they were. That's one of the big revelations, if not scandals, of recent years. It's quite possible that there's a complex trade-off going on for people between having a mild to moderate depression, not having it labeled as such, managing with it somehow, getting better, and not having then the consequences of having been labeled as somebody who has depression, versus saying, oh, I have depression, I'm prone to recurrent depression, all the other story that comes along with that may not always have a good outcome. And I don't think we can make a firm conclusion. I think that we don't know enough about this, and we do know that the simple story and the very positive story that we were told of let's just find everybody who has depression, let's treat them all aggressively, everything will be great, is not correct, it's not sufficient. And that there's definitely a set of trade-offs going on. The other point to be made about stigma here, and again I think we'll come back to it in a variety of ways, is the great hope with destigmatization campaigns in psychiatry. We're in the midst of a huge one here in Canada coming up through the Mental Health Commission of Canada, has been that if we explain mental illness as a biological phenomenon, people will accept it and it will be destigmatized. So instead of people viewing depression as a weak character, or lack of energy, lack of gumption, you should pull yourself up by your own bootstraps, that we would say, no, it's an illness like anything else. It's like catching pneumonia, you need an antibiotic, you need your antidepressant, all these kinds of analogies, or a chronic illness like diabetes, and you need your ongoing medication to prevent. The hope was that those frameworks would really destigmatize. And the evidence is, at least on a global scale, that that's not the case. And in fact, it works the opposite in many places, because people understand the biological explanation as telling you something about the intrinsic character of that person, the intrinsic nature of that person, something genetic, something constitutional, and so it actually confers another kind of stigma. And particularly in many Asian cultures and other societies where people understand chronic mental illness, depression, other things like this, as being, or anything that's explained biologically, let's put it more clearly, so, as being intrinsic to the person and therefore expressed in their inheritance, being passed on to other generations, this has very negative social effects, not only for the person, but for their siblings, for their family, because it's, oh my God, my sister will never get married now because I have this biological illness, so now it's a mark on the family. So it's this kind of hope that this would be a simple solution and that people would just say, great, it's an illness like any other illness, and now we should just be compassionate, has not played out as simply as people thought. Because of the cultural meanings of things like biological illness and so on. Yeah, so this is a complex set of issues again about how do you view an illness or an adaptive problem like depression or anxiety. Do you view it as just something that's happening to you, like it's the machine's not working right, I better take my pill? Or do you view it as part of a process that involves your own agency, your own will, your own strategies for coping, because then maybe there's something you can do about it? So there's a study, take the example of anxiety, there's a study years ago by, I think it's by Malcolm Lader, showing that people who were being treated for panic attacks and who were given alprazolam, an anti-anxiety medication, and cognitive behavior therapy did worse than people who are just getting the cognitive behavior therapy. And there are two possible explanations. One is that if you're medicated, you're not going to be fully alert and able to engage and so on. But the other is an attributional process. That is, what happens with many people when they get these medications, they may not take them all the time, but they have them there, so they have them wrapped in a little piece of tinfoil in their pocket, and they know that it's there whenever I need it. So psychologically, it's functioning as a kind of safety net, but it's preventing the person then from feeling like I've really mastered the situation. I kind of know what to do. I can handle this on my own, which would build up, you know, if you successfully acquired that attitude and showed yourself that you could do it, it would give you a much greater sense of self-confidence. So there's this dilemma again between, on the one hand, wanting to say, look, it's not your fault. This is part of the human condition. It happens to lots of us, et cetera, et cetera. Don't feel ashamed. On the other hand, don't think of this as something totally divorced from your mental attitude and your own capacities and so on, because you can master this. So how can we have it both ways, you know? Or is there inevitably going to be a trade-off that if we go down one route, you're going to have to struggle with the fact that you feel like, well, if only I was a little better at this, I wouldn't be sick, kind of, and you're going to feel the shame and the self-stigmatization, the self-stereotyping, the self-handicapping that goes on with that. So you're raising an interesting question. So because you're pointing out that benzodiazepines are not the recommended first line of treatment for panic disorder. I should say it remains that benzodiazepines are very widely administered by family doctors and by psychiatrists and by everybody for people with anxiety disorders. I see this every month in the emergency room, people coming in with these medications and people being encouraged to be given these medications. So that's the reality. But you're raising an interesting question. Many people would feel if you are going to give medication that an antidepressant is a better medication to give. And what that does for panic disorder is it can block the worst panic attacks for people, so then they feel like they've got a bit of a safety net and they've got a bit of a handle to then go ahead and use other strategies. And the question would be, how does that play out for people? And I should say that even with benzodiazepines, it's not necessarily going to work that way for people. There are people who can take it or have it available and still invest very well in using other strategies. So the point simply to be made is that what's at play even with these pharmacological treatments is what is the meaning of this treatment to people. There's no way to escape from that. And that part of the efficacy is the meaning and part of the side effects is the meaning, if you will. And so we have to understand that. And those meanings are culturally embedded. We live in a culture now in which taking pills has become much, much more acceptable than it was 20 or 30 years ago. When I was studying psychology in the early 70s or late 60s, early 70s, there was a rise in the use of methylphenidate for attention deficit disorder. And then there was a big article in Science decrying this and saying this is a mistake, we're over-medicating, etc., and then it appeared to go down. And here we are several decades later when this has happened in an even larger scale with much less, I say plenty of criticism, but much less actually restraint and much less pushback against this. And I think it's because larger societal attitudes have changed so that it's just much more acceptable for people, the idea that they might take different medications or the kids might take medications and so on. In asking where is the stigma when so many people are taking psychiatric medications, does it mean stigma has decreased or that it's changed its nature and it's attached to different things? That's possible. There's less stigma attached to taking medication. There may be stigma attached to certain kinds of inappropriate behavior, or there's more stigma and anxiety attached to doing poorly in school. Or to saying, in the case of ADHD, for example, there's more stigma attached to saying there seems to be a family problem here and let's talk about the family than there is to saying, oh, this is a brain disorder and we'll give you some medication to help you tune your attentional system. Less stigma and also less threat on many levels for people to treat it as in this kind of neuropsychiatric way than to say, look, let's look at why this kid's having trouble sitting still in the classroom, concentrating, and so on and so forth. Or even the larger question, which Jack Panksepp has raised, a affective neuroscientist who studies the development of emotion systems. And one of the things he studied is play in rats. You know, rats play, little baby rats like running around and nipping each other and everything else. And based on that, I mean, he draws a lot of analogies from rats to human beings, some of which are compelling, some of which are not. I should say also he discovered that rats also laugh. That if you tickle rats, they have very high frequency laughter. It's outside the human range, but I think it's fantastic. You can tickle their bellies and you can hear these, they can show on sonograms these ultrasonic little giggles that the rats are making. So it does make them much more human and adorable in some ways. And in any event, looking at this sort of rough and tumble play among young rats, he pointed out that human beings too, young human beings do a lot of rough and tumble play. There's also a gender difference. Boys do more of that than girls, but both boys and girls normally do some of that. And what we do in our society, of course, is we take boys and kids at the peak of that time, and we say, now please sit in a classroom and don't move for 6 hours a day while we talk to you. So the fact that a lot of kids have trouble in that setting might not be pathology at all, or the pathology is the social pathology, that we've created a weird situation that doesn't reflect human biology and development in that point. So that kind of argument, which is possible, is very hard to study and very hard to make in many ways, because it's so much about just, this is the way we do things, this is our culture, this is common sense, how could we overturn this kind of, Yeah, this is a recent study. I think it's from Canada, this recent study, and it's a great bit of evidence in favor of this argument that the correlation, the likelihood of being diagnosed with attention deficit disorder is directly related to how young you are in the classroom. So if you happen to be, because of your birth date, you happen to be in the younger group in your class, you're much more likely to get that diagnosis. So you could simply say, well, these are just kids who are developmentally a little bit less mature than the other kids. There's nothing wrong with them. It's just harder for them to sit still because they're still, but the response of the system, because we have a very limited set of responses available, is to label them with a disorder and give them medication. And one of the other dilemmas, since we're talking about stigma and medication, so one of the other dilemmas is, once you're given medication, it is a social mark. I mean, the meaning of stigma, of course, is a mark, right? So now you have the social mark that follows you everywhere. And every doctor who opens up the chart and says, oh, you got such and such medication, when did you last take that, it now is, becomes a self-perpetuating reality in some ways. And it's hard to break away from that completely, or to have a new identity now. So these things become part of people's personal histories and identities, internally, but also in communication with others. Okay, let me shift to the other kind of, second kind of somatization I wanted to talk about, which is these medically unexplained symptoms, or functional somatic symptoms, if you will. These are extremely common. Studies in family medicine suggest that probably 15% or more of patients who come in primary care, 15 to 20%, have physical symptoms for which there's no clear medical explanation. As I say, that's partly just because of the limits of medical technology. I mean, people have aches and pains. We think that, if you sit hunched over the computer, you're going to have back pain, but there may be nothing to show in your back. These are very subtle phenomena. We don't have the technology to show it clearly, but it's reasonable that there's something there. But there are lots of other complaints people have that are hard to make sense of. These are the most common. This is from a community survey now that we did again in the Côte-de-Neige area. We looked at 2,400 people, and we asked them, in the last year, have you had a physical symptom for which a doctor could not find an explanation? So these are ones that troubled people enough that they went to the doctor, but the doctor could not find an explanation. So interestingly, almost 10% of people have had such a symptom in the last year. And these are the most common symptoms. 1/3 of them are some form of musculoskeletal pain, abdominal pain, ear, nose, and throat symptoms, fatigue, and dizziness. There are other ones if you go down the list. I think I might have another slide here comparing what men and women reported. You notice that somewhat more women than men reported symptoms, which is commonly the case. Across many different cultures, women tend to report more somatic symptoms than men. The extent to which they do varies culturally, but the preponderance of women is consistent. And they're basically the same. The only difference is men reporting some urogenital symptoms. I'm not sure what that's about. Ear, nose, and throat. So I don't know beyond, I'm trying to remember now how those were grouped. These are our groupings of things based on people's free reporting of symptoms. So it may be sore throat or runny nose or earache or a whole lot of other things. When you ask, so what is associated with having these kinds of symptoms, what you find is that the only thing that's significantly associated here, because all the confidence intervals span one, so the only one that actually is significantly associated is the General Health Questionnaire, which is a list of symptoms of emotional distress. Feeling you couldn't cope with things, feeling worried and anxious and so on. So there is an association. It's not a huge association. It's actually a relatively small association, but there is a connection between emotional distress and physical distress. This is an important point because, again, if you go back to the older psychodynamic literature, there was an implication in the theories of somatization that if you can express distress in emotional terms, you don't have physical symptoms. If you can't express it in emotional terms, it's blocked, and somehow that energy or that tension or that conflict will be expressed in physical symptoms. But most of the research shows that, in fact, emotional stress and physical stress are positively correlated with each other. That means the more emotional stress you have, the more physical distress you're likely to have. So there's not an either or, they actually go hand in hand. And this is another little bit of evidence that that's the case. I should say, I don't know if it's on here, let me just see it's on here. Yes, one of the things, the point of this particular study, I may say a bit more about it at a later point in this lecture series, was really to look at help seeking among immigrants in the same urban neighborhood. So those 2,400 people that we were surveying in the neighborhood included samples from the community of people who had come from Vietnam, from the Philippines, and from the Caribbean, all living in the same neighborhood, because what we were interested in is here are people who are in the same healthcare system. Theoretically, they have the same level of access to the healthcare system. It's free access to care. And how are they using it? And we found that they used medical care the same way, but they did not use mental health care the same way. And I'll say more about that later in the course. So here you can see immigrant status. Again, it was not really associated with reporting more somatic symptoms. When we break it down more, I don't know if I have a slide here showing it, we did find some evidence when we broke it down by groups and so on, that if you talk about not unexplained symptoms, but just somatic symptoms in general, that the Vietnamese sample reported more somatic symptoms than other groups. But the Vietnamese sample was also a sample that included a large number of people who had come as refugees. So it is potentially a more distressed group, at least initially, and I'll say more about that later. Actually, I will talk a bit about Vietnamese idioms of distress. In terms of medically unexplained symptoms, every medical specialty has its own families of medically unexplained symptoms. So these are lists in some of the different, really broken down by organ system or medical specialty. If you're an ear, nose, and throat doctor, you see people with burning tongue syndrome or tinnitus, ringing in the ears. If you're in cardiology, you see people with chest pain, but a normal cardiogram, nothing wrong with the heart as far as you can see. In gastroenterology, very common complaints are irritable bowel, where people have constipation or diarrhea. Nothing can be found to explain it, or abdominal pain, actually, the most common symptom, irritable bowel. And so each area has these things, and these are among the most common diagnoses. That it's a big chunk of patients in each of these specialties. And most medical specialists are a little bit irritated by these patients. They're not the exciting ones. They're not the ones for which there's a clear-cut diagnosis, a clear-cut treatment, etc. But they're the people you have to contend with. There are exceptions. They're rheumatologists, whatever, who are very happy working with fibromyalgia. There are different groups who make it their calling kind of to work with these kinds of patients. But in general, there's a kind of stigma attached to this because it's not well understood, clear-cut problem, clear-cut diagnosis, and always an implication that maybe people are complaining for no reason or complaining beyond what's reasonable in some way. Now, I should say that the fact that they're on this list and that they're medically unexplained does not mean that there may not turn out to be clear biological explanations for these things. It's just a question of where we're at right now with knowledge and with the possibility that there are other processes going on. Now, these kinds of medically unexplained symptoms are also influenced by culture. So the way that people diagnose in these epidemiological studies somatization is usually not with unexplained symptoms, because that's hard to figure out. You ask people for symptoms in general. In the case of the diagnostic interview schedule, you have a list of a bunch of symptoms you ask people about. And you do say, did you ever see a doctor for this? And did the doctor have an explanation? And you write in the explanation, and then later on, because these are done by lay interviewers, later on a clinician is supposed to look at these and decide, is that a plausible explanation or not? And if it's not a plausible explanation, it counts as a medically unexplained symptom, and you add up enough of these, and if you have a lot of these, then you get a diagnosis of having a somatoform disorder. When this kind of work was done in the United States, and they looked for people who had lots of medically unexplained symptoms, they found lots of people who had a few, but very few people who had many. And I'll say more about that in a moment. But when they did this in Puerto Rico, they found lots of people who had medically unexplained symptoms. And in particular, they found lots of people who reported some of these symptoms of fainting, of paralysis, of temporary loss of neurological functions, loss of consciousness, and so on, and this was very strange. And it led to a very high prevalence of somatization disorder, the most severe form of somatoform disorder in Puerto Rico from the Puerto Rican ECA study. And this was a big question, what's going on here? And this is some analysis from later studies showing that part of what's going on is if you look at Puerto Rican culture-bound syndrome or idiom of distress or some mixture of the two called ataques de nervios, nervous attacks, that prototypically what that consists of is a person gets some bad news or something happens, they become extremely agitated and upset, shouting loudly, crying out, and they fall unconscious to the ground or show other extreme behavior of that type. So this is a common reaction to very bad news. You can find some YouTube videos online showing people having these reactions. There's one where people are at an airport and they've just heard that there's been an airplane crash and people are showing these dramatic responses. I say people from every culture would show a dramatic response, but there's a particular cultural script for what this looks like, and it's called an ataques de nervios, and it's understandable to other people. It doesn't mean you have a psychiatric problem per se. And as a result of this, when you go and do this checklist with people and saying, by the way, have you ever had a period where you lost consciousness? Lots of people say yes. Whereas in the United States, very few people will say yes. So you have an interaction then between the basic tools we have of trying to ask about symptoms and a cultural framing of a behavioral pattern here that may be part of a syndrome and part of a way of talking about distress. So, and ataques de nervios is one of the best studied of these syndromes because there's been epidemiological work and a lot of other things, so we know something about how it works. I'll come back to that. In DSM-3 and 4, there's a group, as I mentioned already, of these somatoform disorders. This is the list in DSM-4 of somatoform disorders. And these are important partly because, again, of the segmentation of care. Because if you go to a hospital and you have abdominal pain, you get to see the gastroenterologist. But after the gastroenterologist decides, I can't figure out what's going on with you, there's nothing wrong here, he calls a psychiatrist or a psychologist and says, help. And so these disorders serve the function of plugging the gap in the system. And it ensures that everybody, no matter what their problem, gets a diagnosis. You have pain, we can't find the source of it. Okay, you have pain disorder. It's a psychiatric problem. You see how it functions, a little bit of magic there, where we just fill the gap. So it's a very important institutional function that is problematic in certain ways, partly because we don't really understand well these problems, and partly because it carries the stigma again that we're going to ask the psychiatrist to see you. When the psychiatrist arrives and says, your doctor asked me to see you because you're having a lot of pain, the person's first reaction is, why did they send a psychiatrist? I'm in pain, I don't need you, I need a painkiller. So you have a real dilemma of negotiation about what it is you're going to do to help people, understandable. I'll just describe these disorders very briefly for you. Somatization disorder, which in an earlier iteration was called Briquet syndrome, and before that was called hysteria, essentially, is a syndrome of many, many unexplained symptoms. In DSM-4, I think 3 or 4, you had to have 13 symptoms unexplained. So lots of different symptoms. In DSM-4, it's simplified in a way, the diagnosis. And they have to be symptoms in all different physical systems. So it's not just in one area. It's not just, let's say, fibromyalgia. All the symptoms are in the area of musculoskeletal pain, for the most part. And it's viewed as a lifelong problem of experiencing many somatic symptoms and being disabled by them. The risk associated with it is that you'll get all kinds of medical investigations and procedures and end up with further problems created by that, and so it's a significant issue for people. I should say that in the ECA studies, the United States, the epidemiological catchment area studies, when looking for somatization disorder, they found almost no cases. So this had been a well-described syndrome in Washington University in St. Louis by Samuel Gouset and the group there. And Chris Bass, a British psychiatrist, then published, I don't think I have the slide here, but he published in a book on somatoform disorders, he published a chapter on somatization, and he had a little diagram of Missouri and the surrounding states, and he said, somatization disorder is a culture-bound syndrome of the American Midwest. And some clue as to what might be going on there happened some years ago when psychiatrist moved from the Midwest to Vermont and was operating in a different environment, and discovered that people who in the Midwest would be labeled as somatization disorder in the East Coast get labeled as borderline personality disorder. Because if you talk to people with borderline personality disorder who have a lot of emotional distress and a lot of things going on, they have lots of physical symptoms, all kinds of physical symptoms. And they often have all kinds of medical procedures to deal with those physical symptoms. So this sort of domain distress in every domain gets looked at. It's like the famous Parses and the elephant kind of story, you know, that to a psychiatrist in one part of the world, what's interesting is the list of somatic symptoms, and another part of the world is the list of relationship or emotional symptoms. But these are people who are distressed across the board. So that may be part of what's going on and why these things were not always detected. And that's both on the part of the psychiatrist, but also on the part of the person who's suffering. Conversion, sorry, please. Sure. Well, hysteria is the sort of older term. In fact, it's a very old term. It goes back to Greek times, and the origins of the word have to do with the notion of a wandering womb. That's why we get hysteria. So the definition is the idea that the womb would wander around the body and cause all kinds of symptoms by pressing in different areas, and so it has a very gender-specific or sex-specific definition in terms of how one would get those symptoms. And there's some continuity in descriptions of symptoms going back again a long time ago up to the present. And of course, hysteria was right at the center of the emergence of psychiatry as a discipline in the work of Charcot and then Freud and Breuer and so on, who moved essentially Freud from being a neurologist to being early psychiatrist. So, and the bread and butter kind of work that people were doing at that time was dealing with people with conversion symptoms and hysteria. What happened with DSM-3, there's a historical paper that came out around the time of DSM-3 called Hysteria Split Asunder, in which the whole variety of things that were put in hysteria got put into 3 different places in DSM-3. Into somatization disorder, into histrionic personality disorder, and into conversion disorder. So somatization disorder I've already described. These are people who have many, many different kinds of distressing symptoms that are medically unexplained. Conversion disorder is a situation of people who have single or a few symptoms that are pseudo-neurological. That is, they look like a neurological disorder, like paralysis, blindness, seizures, for which there's no biological explanation. So somebody looks like they're having seizures, but if you measure their EEG at the same time, it's normal. So these are behavioral seizures, if you will. And that's literally how the diagnosis is made these days. You have a split-screen monitor, and on one side you're recording the EEG, and the other side you have the video of the person, and you can see there they are thrashing around. Looks like a grand mal seizure, but there's no abnormal electrical activity in the brain. So you can sort of fairly definitively say whatever this is, it's not a seizure. And similarly for other kinds of problems that you try to show that the expected neurological thing is not there at all, and so what you have is something that looks neurological or looks like the person's map of neurological. So if somebody gets, let's say, numbness, they will in the hand, they will not get numbness following the actual pattern of the dermatomes that reflect the nerves. They would get what's called glove anesthesia. The whole hand gets numb, which is a lay notion of how it should be, but not an anatomically correct notion. So it's those kinds of mismatches that are the clue to the neurologist that, wait a minute, this doesn't make sense. It does not follow the actual structure of the nervous system. It's really being driven by the person's model, their mental model of what this illness should look like. So those are conversion symptoms. And the third area, as I mentioned, is histrionic personality. So histrionic personality now is viewed as a personality style in which a person is very dramatic, very emotional, very vague and circumstantial about things and so on. So the prototypical description of hysteria, again, was all these 3 things together, and these are like the early cases that you can find in Freud's case studies. And this, with DSM-3, was an attempt to say, okay, there might be something in each of these areas, but they don't all go together, and there was evidence that they don't all go together. So let's separate them out, and we can study each of them separately and look at them. So that was the argument. And in terms of taking hysteria and turning it into somatization disorder, I mentioned the intermediary was Briquet syndrome. This is what, again, the St. Louis group proposed, coming out of the work of a French neurologist, Briquet, who described people with many different symptoms and in a way that they felt, fit the kind of construction that they were working with. The other things listed here are hypochondriacal disorder. So these are people who are very worried about being sick, may or may not have a lot of symptoms. Pain disorder, so this is people who are complaining of pain beyond what would be expected or can be explained by their physical condition. This is, again, another problematic category because, as Ron Melzak here at McGill and other people argued, we don't really know what the right amount of pain is for any given thing. There's huge variation. For the same injury, you can break a bone, exactly the same bone, or have a dental procedure, exactly the same thing, and there'll be enormous variation in terms of what people experience, so who's to judge? Not only that, but if you think you can judge how much pain somebody is in by how they're acting, it's not the case. In fact, our ability to judge how much pain somebody else is in is very poor. And clinicians' ability is very poor. Clinicians think they can tell how much pain somebody's in, but there have been studies literally where they put an actor there and say, I'd like you to pretend that you're in a lot of pain, or somebody who's in pain tell them, I'd like you to pretend you're not in pain, and you can show that actually clinicians are no good at judging at all. So it raises a lot of issues because a lot of decisions are made in clinical settings based on nurses or doctors' subjective impression of what does a person really need, and are they over or under reporting, when in fact it's not so straightforward. Body dysmorphic disorder, which is quite a different thing from some of the things we're talking about, which are people who are convinced that there's something misshapen or ugly or wrong with their body. And this comes up again in hospital settings a lot because people come for plastic surgery. People say, I must have my nose changed, it's too big. And so there has to be some decision. Is this a reasonable request? You can see what a sociological conundrum this is in terms of what's a good nose to have. There's a whole history on that. You can read Sandor Gelman on a whole history of that. Or people who, I remember one of my colleagues had a patient who insisted that her eyes were too close together, which nobody else could see. I mean, that's the other issue, that some of these things you would agree and say, yes, you need, plastic surgery maybe will help you because you have some deformity. I mean, that's what the medical side of plastic surgery is supposed to be addressing. But then there are these other things that appear imaginary or delusional or so on. So this is a category for that kind of concern. The latest theories are that this is most closely related to obsessive compulsive disorder, actually, in which people are sort of focused in on some aspect of their body and kind of obsessing about it in a way that's problematic. And then we have these two residual categories, which is typical for the DSM, that there are always these sort of wastebasket categories. If you have some of these things but you don't reach full criteria, you go in these categories. One of the consequences is these are always the biggest categories. Because if you just have a few physical and unexplained symptoms, there's no place to put you except in these residual categories. So they're actually pretty big categories, but they're not used that much. What I'd like to do then is continue along talking a little bit more about this whole idea of medically unexplained symptoms or functional somatic symptoms, the idea of these common symptoms of fatigue, of pain, of all these other kinds of things that are so prevalent in the community and in primary care, and to think more about what might be going on. If we can't find a clear illness, a clear medical disease explaining these things, what might account for these symptoms? And here's some of the things that we find in association with common symptoms. The first thing is negative affectivity or neuroticism. This is a personality trait. Those of you who know sort of contemporary personality theory know that the psychometric theory argues that there are 5 big factors that you can find from around the world from using many different kinds of personality tests, and one of these is a dimension called negative affectivity. And this is associated with high levels of symptom reporting. To some degree, it's circular because the questions that define negative affectivity are, do you have a lot of complaints and physical symptoms and so on. But even if you take those away and you use other ones, you can still find this kind of dimension, if you will, of this kind of distress in people. Another thing that's associated with reporting many medically unexplained symptoms is a lot of childhood illness experience. So there's something that goes on in which children spend a lot of time in healthcare settings, either because they have illness or because their parents are worried about them having illness and so on, that may reinforce illness behavior. And so, and we'll talk again about what some of the processes might be underneath that in a moment. Another thing that is found is a tendency to make pathologizing attributions, or more particularly, and more accurately perhaps, a less likelihood of making normalizing attributions. So let me explain what I mean by this. Whenever you have a symptom, you have something that happens, you're sitting here today and you start noticing that you're feeling a little bit warm. And you can think, ooh, am I getting a fever? Or you can think, it's warm in the room. Or you could think, oh, I must be feeling embarrassed. I mean, those are all possible explanations for feeling warm and flushed in the face. The first one is a somatizing or an illness attribution. I have a fever. The second, that it's warm in the room, is what we could call, it's an external attribution. It's also a kind of normalizing attribution, because that's not a pathological condition. It's just an ordinary state of affairs. And the third is a kind of psychologizing attribution. Oh, I wonder if I'm blushing, or maybe I'm feeling embarrassed. Those are all available to us all the time, and in reality, we're all doing that kind of processing all the time, right? I mean, and as you get older, I can tell you, sorry to tell some of you, you do more and more of that kind of explaining of things. And you have a range of things to attribute symptoms to, based on your own experience, based on what's available to you. And the most common types of explanations, the healthy ones under other circumstances, are to normalize things. You feel a bit stiff and you think, I need to get more exercise. I must have not slept well last night, or I'm out of shape or something. And that's it. Or you feel a bit of your heart pounding, you think, oh, maybe I had too much coffee today or something. You come up with some explanation that reassures you, and that's the end of it. And that's a normal process of managing everyday experiences by attribution. Well, it turns out that if you look at people who have a lot of medically unexplained symptoms, and people who go for help a lot for that if you just give them a paper and pencil test where you say, okay, suppose you had a headache, what are all the explanations you could think about? They don't generate as many normalizing explanations as other people. So they're less able, for whatever reasons, or less likely to explain away symptoms and reassure themselves. So this is an area we've been particularly interested in, because this attributional process, which is a very cognitive process, is one kind of thing where you can see culture operating all the time. And it's also a very malleable thing. It's something that you can work with in cognitive behavior therapy and so on with people to modify. So there's a lot of interest in the role that these kinds of attributions might play in symptom experience. Anxiety and depression are both correlated with these symptoms. I mentioned already, I showed you some of that evidence. So these can be part of it. When you look at clinical samples of people in a clinical setting, you find a much stronger correlation between anxiety and depression and these symptoms than you do when you look in the general population. And that's because of a kind of bias in epidemiology that's called Bergson's bias. Because if you look at a clinical sample, you're seeing people who've come for help. Take the example of fibromyalgia. Fibromyalgia, muscular aches and pains of the type we were talking about earlier, is very common in the general population. Most people who have that for a little while don't come for help. They manage on their own. They take an aspirin, Tylenol, they go for a walk, they just say, oh, I need to get more sleep, whatever. Those people who do come for help have a significant prevalence of depression. It's not because the depression necessarily caused their symptoms, but the combination of the symptoms and the depression is enough to make them think, I can't bear this, I got to go for help. So this is a general problem in epidemiology. It's not specific to fibromyalgia or anything else we might want to talk about. When you look at a clinical sample, you see a subset of people who've been driven to seek help, and things that might push a person to seek help are then mixed into the sample and overrepresented and may appear as a high proportion in that sample, when in fact they're not directly related. They're related to help seeking, in other words, not to the specific symptom you might be looking at, or at least that's a possibility. I've mentioned life stress. Clearly, when you ask people, what's going on with your symptoms, you get stress explanations, and you can show those correlations more generally. And then history of trauma. And this is an area of great interest and has been in recent years, because of the idea that somehow severe physical or psychological traumatic events could leave a mark and be expressed in a lot of somatic symptoms, and in particularly unexplained somatic symptoms. So there's been a lot of interest in that. And the variety of kinds of studies that have looked at this, this relationship is found a lot in the United States, not a lot in other places, so it raises interesting issues about cultural modes of explaining and talking about things. But years ago, James Pennebaker, a social psychologist who studied physical symptoms a lot, did a study with one of his classes, big psychology class, where he asked people to rate a long list of symptoms. And then he asked them, as an anonymous questionnaire, he asked them, have you ever been abused, or have you ever, had any kind of sexual, I don't remember the exact questions, but there were some questions he asked about sexual abuse and so on. And he asked, have you ever told anybody about this? And what he found that was very interesting was that there was an association between somatic symptoms and a history of sexual abuse that the person had never talked about. So this kind of fit with a theory that said there is some kind of cost, some kind of cognitive, emotional, physiological cost to having had a bad experience and never being able to talk about it, or feeling you can never talk about it. So it doesn't go away, you have to rehearse it and keep putting it away, keep suppressing it, and his argument was that kind of suppression was having an effect and resulting in physical symptoms. So this is an intriguing idea. There's some evidence for this. It's not, I think, as well supported as one might like, so this is another dimension. Yes, there are hereditary factors. Negative affectivity, for example, the personality dimension I talked about, is a heritable trait. So that's one way in which hereditary factors come into play. If you have parents or grandparents or whatever who are very crabby people who had lots of symptoms of distress, you're at increased risk to have that personality trait and to show that yourself. That's one pathway. There are other dimensions. So as I show you some of these other things, you can imagine how some of these other things have hereditary components. But as with most hereditary psychological things we talked about before, these are non-specific in the sense that they can lead to many other things. They don't just lead to medically unexplained symptoms, let's say. It's not a straight pathway. And they are, by themselves, most of these things, modest influences. That is, they're not sufficient by themselves. They're just one other factor that piles up with a bunch to give rise to things. Something like negative affectivity, for example, it depends a lot on your life experiences how much you're going to express that personality trait. You can have that trait in a mild form, and if you have a lot of adversity in your life, you'll probably show it, express it, and show the consequences of it in a much stronger form. So this is a model based on that this kind of research, a lot of research on symptom experience and reporting and other kinds of things that puts together some of the factors that likely play a role in people's experience and expression of physical symptoms, not only of medically unexplained symptoms, but actually any symptom. Most of what I'll have to say now has to do with somebody with with heart disease who actually has identifiable heart disease and how much they're experiencing or reporting their symptoms, or anything else we might think of. So at the top you see two boxes. One says physiological disturbance, so things can happen that disturb your systems. For example, you can drink too much coffee and have your heart beating too quickly, as I was talking about before, or you can drink too much coffee and have stomach pain. Or disturb your gut and have abdominal pain from that. You can also have a lot of emotional arousal, and it will give you similar kinds of symptoms, depending on the type of emotional arousal. Depression causes one set of symptoms, anxiety another set of symptoms, anger another set of symptoms. They overlap, but they're somewhat distinct, so you can get symptoms that way. What happens then is, do you pay attention to these things or not? They're going on, whether you pay attention or not, they're sort of there to some degree. Maybe like a background, you can think of it as a kind of white noise in the background. And the question is, do you pay attention to it? Now, why you pay attention to it has to do with a lot of factors. James Pennebaker, I mentioned earlier, did a lot of interesting studies to show that the attention you pay to things depends on environmental circumstances. If you're a runner, cross-country runner, and you run on the same track, a little like we used to have in my high school, a little track in the back, and you just run around. It's a small track, and you're running around the same track over and over again. You'll experience a lot more fatigue and muscle discomfort than if you're running across country on an interesting environment. And it may even be harder to run cross country on an uneven ground, but you will go longer and experience less distress. Why? Because your attention is drawn to things outside instead of to your body. And so you're just not paying as much attention to the discomfort you have in your body. So that's a very simple example. Another interesting example he did was he went to movies and he rated he recorded the amount of coughing in every like 1 minute period of the movie, and then he took the movie and he had a panel of people rate how interesting is the movie at this point from moment to moment. And you can show a very clear correlation. Boring parts of the movie where people agree, yeah, that's a pretty boring part of the movie right now, the level of coughing goes right up. So what's going on there? Well, I mean, everybody's got a little phlegm in the back of their throat. I'm sorry to remind you all of that right now. But anyway, and then what's happening is one person is clearing their throat, and whether you hear that or not and pay attention to that or not depends on how absorbed you are in the movie. If you're very absorbed, you're not even paying any attention to that. You're just watching the movie. If you're not absorbed, you notice that. It makes you pay more attention to your own throat, and you notice, I can't resist it anymore now, that you have to clear your throat. So it's an attentional process. It's also a social process. You notice that there's that interaction going on, both in terms of the external environment and stimulus and your relation to other people. How much attention you pay to other people is not a neutral phenomenon. It depends on how much you like them, how much they're like, you feel like them, that they're similar to them, and so on. All these other things are playing a role. So you've got all those dynamics all around attention. Once you notice something, once you pay attention to it, you have what we just talked about, this attributional process. Okay, I notice I have this thing in the back of my throat. I wake up in the morning and my throat's feeling a little bit sore, and I start thinking, could it be that I'm getting a cold, or is it just dry? You know, I mean, I've got different explanations available, and what I'm going to think is going to be based on what's been floating around. A man of my age who wakes up in the morning and feels pain in his chest is likely to start thinking, I wonder if this is, a cardiac problem, And moreover, if you have a friend who last week had a heart attack, that's going to be much more salient in your mind at that point, and you'll think that much more. It'll be harder to get it out of your mind to convince yourself it's not important. So this is all process of attributing sensations. You can attribute them to illness. If you attribute them to illness, then the question is, okay, how serious is this? And are you going to say, okay, yeah, maybe I'm getting a cold, no big deal though, I'll have a cup of tea and honey and get on with my life? Or you worry, oh, I hear there's a horrible flu virus going around, this could be really serious, and you start worrying more. At that point, if you start worrying more and catastrophizing, you create more emotional arousal. So I've drawn some of the feedback loops. They can exist at many levels. I've only drawn a couple of them, but this is a particularly important one, because at that point, if you have made certain attributions and now you start catastrophizing and you get very emotionally aroused, you've now got lots more symptoms. Because as a result of having all this worry and adrenaline floating around in your body now, you actually generate new symptoms. So this is a vicious circle, and this essentially is part of the vicious circle that is the theory, cognitive behavioral theory, or emotional theory of cognitive emotional theory of panic attacks, essentially, or if it goes on more slowly, of hypochondriasis. It goes through indolent, slow, vicious circle, it's hypochondriasis, very rapidly escalating one, it's kind of a panic attack for people. There are probably other differences too, but there's a lot of similarities in those two situations. Well, once you've decided you have a health problem, you have to decide what to do about it. So, as I say, maybe you just take some aspirin or drink some tea with honey, or take some other remedy, or maybe you say, I better go for help. And then you go for help based on your idea of what's available to me economically, socially, what's appropriate to do for this problem, what kind of healthcare system am I in, and you avail yourself of that. Once you start interacting with other people around your problem, whether it's somebody in your family or going to see a healer or whatever, you're then involved now in an interpersonal process where your way of reporting things is being responded to by other people. And there's interesting work around this. For example, if you complain of pain within a couple dyad, how the other person reacts to the pain has an influence on your pain experience. And the processes can be unintentional and even paradoxical. So somebody who expresses a lot of solicitousness and concern about your pain may inadvertently be reinforcing your pain experience. Somebody who ignores your pain might help to dampen your pain, although they will evoke other feelings of neglect and anger and frustration. So it's a complicated process there. But there is research showing that in chronic pain situations that sometimes couples get caught in vicious circles in which a lot of attention is being given to somebody who's in pain, and inadvertently that's reinforcing the pain, not just pain behavior, but pain experience in some ways. This can happen on a social level. So there's a famous case study in Australia of repetitive strain injury. Some years ago, there were people who started showing up at their doctors complaining of sore wrists. And they were people who were working in video display terminals in the early days of introducing computers, and they were working long, long hours typing in stuff, and they were getting very, very sore wrists. And the doctors who saw this started diagnosing RSI, repetitive strain injury syndrome. The theory was that, having to do this kind of thing for hour after hour was causing micro damage and injuries to the wrist. Not carpal tunnel syndrome, which was another kind of thing, but a problem. People started getting doctors' notes saying, this person has RSI, they need time off work because, this is really hurting their hands and it's a serious problem. And over a period of several months, the frequency of these cases in Australia began to grow exponentially. So at some point it caused some alarm in the insurance companies and other people and thought that this is a problem now, it's going to be very costly, and they started some investigations, and they discovered, first of all, that there was no easy way to document in most cases anything. It's what I said earlier, that it doesn't mean there isn't an injury there, but at the level of what we can do in medicine, there's nothing to show. If you don't have carpal tunnel syndrome or something more dramatic, there's not much we can show. And so finally the government decided, along with the insurance companies, that they were going to not compensate people for RSI unless there was documentation of some physical injury. So with the number of cases having grown exponentially over a period of time after they instituted this new change in policy, the number started falling away. So it's an interesting issue what's going on here, right? Is it that this problem was created? It was a factitious problem that was just created because people were being reinforced? Or is it a problem that was there and that was just being ignored by a heartless, draconian healthcare system? The other dimension to this thing that you should be aware of is that the people who were involved with this problem were mostly immigrants to Australia who were working in very low-paying jobs in very difficult work circumstances, very long hours. And so it was also the case that not only was this work distressing to them, but that was the only option or avenue they had to get some kind of a way out of their kind of predicament, was to go to the doctor for these symptoms. So there was interesting discussion afterward. First of all, I'd say that the exponential rise and then the decay of this problem with this change in social intervention speaks very clearly to the idea that there can be a kind of social reinforcement, a kind of social looping effect, if you will, that reinforces and changes and reinforces bodily experience. And then there's interesting papers in the journal Social Problems and other places where some of the people involved with unmasking, as it were, the social nature of this reinforcement pointed out that in giving the social analysis, they were also undermining the, removing the sort of agency, the limited agency available to these immigrants who were in a fragile position in the healthcare system. So it raises a very complex ethical question, because the fact that something is reinforced or that something is extinguished does not mean it's not real. As I say, you can, every pain from any cause can be amplified or can be reduced by these phenomena to a degree. So it doesn't mean people weren't having injury to their wrist, but it's a very striking example of this kind of social change. So this is just the same diagram again, just pointing out that we have some processes that we might call psychological in a sense, that they represent how people are managing things like attention and attribution and interpretation. We have processes that we could view as fundamentally interpersonal. How are other people then reacting to you and responding to what you're presenting or provoking things from you? And then we have larger social processes, which I've talked about here as discursive processes. That's only one way of talking about them. Discursive meaning that these are discourses or languages or linguistic practices that exist, such as the idea that there is a thing called repetitive strain injury, and it is a diagnosis that can be made by certain kinds of clinicians, and it has certain consequences and so on. Calling it discursive highlights one level. It has other dimensions. It has institutional dimensions, it has technology attached to it, and so on. So it's just a way to highlight that this is a larger social process, not strictly interpersonal in a sort of small-scale local dyadic sense, but it has this larger institutional embedding. And so if you think of what can cause symptoms at each of these levels, their phenomena at each level that can be studied in their own right, can be the source of amplification of problems independently, and could be the source of interventions, could be the target of interventions, in effect. So I think you see how this is where we're heading here in terms of how this very general discussion that I'm giving you, that we could say belongs to health psychology more than anything else, is leading us toward a point of view that we can really make use of to think cross-culturally. And I think it's important because, as I say, it began with pointing out that there was this early literature saying people in other parts of the world outside of the West somatize. They complain of physical symptoms when there's no clear biological basis. They express psychological problems in somatic terms and so on. And I think what I've argued so far to you is that actually that's a universal phenomenon. That's the nature of suffering for most people. And that the balance of focusing on one type of symptom or another, attributing in one direction or another, and so on, has to do with all of these kinds of processes, which are both psychological and socially embedded. So here's how this plays out then in a particular context. I don't know how readable this is, and it doesn't matter too much for my purposes. This comes from some of Devin Hinton's work. Devin Hinton is a psychiatrist anthropologist working at Harvard in Massachusetts and in a clinic in Lowell, Massachusetts, where he works mainly with people from Southeast Asia, from Cambodia, from Laos, and other countries in the region. And that's where he did his doctoral work, so he speaks some of the languages of that region, and he's able to work very effectively then with people coming as refugees with a variety of problems. And he has described a series of culture-specific panic attacks. People who get panic attacks, for example, they stand up, they've been lying down, they stand up quickly and they get a moment of dizziness, what's called orthostatic hypotension. Anybody who lies down for a long time and gets up suddenly might have a moment of lightheadedness. Some people have more than others. Older people, people with low blood pressure, a variety of things. But it's not very pathological, and it just goes. But some of these people from Cambodia and elsewhere will, in getting up, will feel that dizziness and will immediately think, oh my dear, I'm going to have a stroke. That a wind is rising in my body and I'm going to have a stroke. And they have a panic attack. So he's described orthostatic-induced panic attacks, which have not been previously described, and which are prevalent in his population. So you have a model like the earlier diagram I showed you, where you can see what the vicious circle is like. You do something physiological. It causes a physical symptom of dizziness or lightheadedness. There's a clear mechanism for that we can talk about, physiological mechanism. You notice it and you interpret it a certain way. That's cultural now. And the interpretation has catastrophic implications to you. So you then have a lot of adrenaline and feel more lightheaded and have other symptoms, and away you go in this kind of vicious circle. He's got a lot of other things written here because, in fact, there are other things going on for people. Because this is a highly traumatized population. There are all kinds of associations people have to that lightheaded feeling. Not only the ethnophysiological idea, the idea that comes out of their own understanding of how the body works in terms of balance of winds and energies and so on, that could be manifested this way, but also remembering traumatic events and so on. And in fact, the possibility that something like PTSD itself and the sort of the sequelae of trauma could contribute to an increased likelihood of experiencing things like orthostatic hypotension in the first place for a variety of reasons. So there's all these different loops going on, but that one main one is, I think, sufficient to make the point. And the intervention, I mean, the main intervention in the current sort of treatment of panic disorder is to teach people to reattribute what's going on, to tolerate the feelings, to not catastrophize and so on, to show them that that makes a difference and give them a handle on the whole thing. And in this case, you can do that very specifically by dealing with people's beliefs and by giving them strategies for coping with it. This illustrates, incidentally, a lot of larger issues, some of which we'll talk about tomorrow, because one of the challenges in thinking about cultural issues is saying, do we need new diagnoses? I mean, where does culture come into play? So should we, in fact, say, this is not now, this orthostatic-induced panic attacks is a separate diagnosis, this orthostatic panic attacks? And should we have olfactory-induced panic attacks? I think the next slide is a slide from his olfactory-induced panic attacks. Oh, this is neck focus, sorry. So the earlier one, sorry, this was olfactory. This is olfactory-triggered panic attacks. So this is a panic attack triggered by certain smells. And he has a whole theory of that in which the smells are causing people to remember traumatic events and so on, and it's causing this thing. This is the neck-induced ones where people twist their neck and feel a bit of dizziness, and that causes panic attacks. So you have, do each of these warrant a separate diagnosis, Or do we want to say, look, the basic mechanism is the same, and we can describe it at a fairly abstract level and say this is what happens when human beings experience a threat, feel frightened, interpret the sensations in such a way that it generates more physical sensations of a similar type, and that's the vicious circle. And then now, having that general model, let's add all the specifics, because anytime we deal with this, whether you're dealing with a middle-aged North American man who's worried that the tightness in his chest means a heart attack, or you're dealing with a Cambodian refugee who's convinced that the lightness in their head means that the wind is rising in their body and they're going to have a stroke, that in any case, to begin to talk to them about how to reattribute this and how to deal with this, you're going to have to deal with the culture specifics of where their belief comes from, why they believe this so strongly, what counter-evidence would be for them, and so on and so forth. So I would argue that that's, for this type of problem, that's a better solution than saying we really need 500 new panic disorder diagnoses. In fact, it's open-ended because there'll always be new ones. If somebody invents a new kind of problem tomorrow or finds a new body position to put themselves in, we'll have a new kind of panic attack. So what I've argued in showing you this model is that a lot of problems people have related to somatic symptoms have to do with vicious circles, actually. And that's what makes them into a clinical problem. What makes them really severe, what makes them more than manageable in an ordinary way is the vicious circle. So this is an attempt to say, what would a psychiatric nosology look like if we weren't describing discrete disorders based on symptoms, but we were describing disorders based on the type of vicious circle, which actually is quite interesting both theoretically in terms of mechanisms and clinically in terms of when you're thinking about where to intervene. Because in reality, many of these loops would be involved in any given case, and you intervene where you can. You intervene where you have leverage. It's not always the initial loop that caused the problem that you intervene in, because sometimes you say, well, I can't do that, but I can do the other thing. I can work on another level. So I think this is more of a, what can we say, a prospect for developing things rather than a well-worked out idea, but I think it's something that is interesting to reflect on, that we might have a typology of what I'm calling here looping effects. Calling them looping effects or feedback loops or vicious circles. Using the term looping effects alludes to another idea that I'll talk about tomorrow coming from the philosopher Ian Hacking and about these larger social processes of looping. But the more familiar one for most of us is just this idea of a vicious circle. And as I say, it's pretty well worked out within the cognitive emotional theory of panic and hypochondriasis. It's also interesting to use the same diagram and think about our interventions, because in effect we have interventions that target some of these different levels, and it's part of how you can think about these interventions. We have interventions, for example, that work specifically on attributions. You're very worried about this feeling you have, but we'll give you a different way to explain it and encourage you to use that different way and see what happens when you approach it that way. Or you're very preoccupied with your body, we'll teach you different attentional strategies so that you can not pay so much attention to your body. And that might be by distraction outside, or it might be by using your ability to focus very intensely, but training it on something else. So that's the idea behind things like hypnosis, let's say. And then we've got interpersonal methods and so on. Okay. What this model of the psychological processes and social processes of shaping symptom experience implies is something beyond just understanding these types of disorders, because it actually has important implications for how we understand symptom reporting in the first place. Because the implication is, whereas in medicine there's an assumption that if somebody tells you they feel hot in the head or they feel tired, that they're simply reporting something that's happening in the body. That's what a good historian is in medicine, somebody who accurately tells you what's happening in the body, what happened recently in their life, and you can just take all this information down and formulate things. But the model I've just showed you suggests that whatever people are reporting is not simply a product of what happened in their body. It's also a product of what they were paying attention to, how they interpreted it, how other people reacted to it, and that's been happening over time. From the moment they first notice something to several weeks later when they finally appear in the doctor's office, there's been this loop going on round and round and round over and over again in which there's been a kind of shaping and reshaping of their experience. So this implication at the top that what should be happening in symptom reporting is that something happens in the body and the person has an experience, this one-to-one relationship, and now they report it. And ideally it's just a straight path through. That in fact that translation process is embedded in all of these interpretive processes. So therefore, that symptom report that you get from somebody already influences all the way down this kind of process, deeper and deeper into all these social things. So this reality, I think, is not fully taken on board in terms of how most clinicians think when they're talking to a patient. Equally, when researchers go and do epidemiology, they're sort of assuming people are going to give you a report, and that's an accurate index. You know, semiotically speaking, it's what in semiotics is called an index. It's something that just shows that something is there. I mean, a simple index would be, if you have fever, you put a thermometer in your mouth, you take it out, it shows your fever. So the position of the mercury or the digital things on the readout are an index of your body temperature. But your subjective experience of whether you're feeling hot or not is not simply an index of your body temperature. It's a much more complex production. It's related to your body temperature, but maybe not so closely. And interestingly enough, in terms of the problems earlier that I was talking about of somatization, of medically unexplained symptoms, people who report many, many symptoms and seek help a lot tend to be less accurate about what's going on in their body. People who are high utilizers of healthcare and who report many, many symptoms tend to be less accurate about what's going on in their body. Why? Because what's influencing their symptom reporting is a lot of this other stuff going on in between. I mean, it's true for all of us all the time, and we can all be in a state where certain things are overriding, but on average, those people who seem to be making very high use of healthcare out of proportion to their medical problems at that point in time, there's more stuff going on between whatever might be going on in their body and their symptom reports. More of this cycling around with them attending, interpreting, other people interacting, all these other influences shaping their experience. This leads to a reflection on, well, what does it mean when somebody has a symptom? How are we going to interpret symptoms? Somebody comes and they're expressing bodily symptoms, how should we interpret these? And we have many ways available, and you can find different literatures in medicine, in psychology, in anthropology, different kinds of literature talking about symptoms in different ways. So as I say, the most basic medical view is that a symptom should be an index of disease or physiological disturbance, right? That the person says they're hot and they should have, high temperature. Or a person says they feel nervous, they should have signs of a nervous problem. There's also a way in which symptoms can be an index of psychopathology. And I mean this not only that if you say you have hallucinations, you have hallucinations, but that, for example, your way of describing the symptoms could be showing that you have a certain kind of psychopathology. So there is a theory that if you have a lot of physical symptoms, you may, as I mentioned earlier, there's a psychodynamic theory that argues you have a lot of physical symptoms, it's because you can't express your emotions and resolve your emotions effectively. This was given the name alexithymia at some point in the 60s by Peter Sifnios, arguing that many kinds of psychosomatic problems were associated with an inability to express emotional conflict and psychological conflict and resolve it symbolically, and instead it was being expressed through somatic symptoms. So in that theory, if a person reports lots of physical symptoms, it's an indication that they have a certain kind of psychopathology, in this case alexithymia. So that's another way of interpreting these things. Another form of interpretation comes out of the work on conversion symptoms, where somebody, let's say they're blind, they suddenly go blind, there's nothing physiologically wrong with them, this is a puzzle, what could be going on? Well, one kind of explanation going back to Freud and Breuer and up to the present is this has some symbolic meaning. There's something the person doesn't want to see, and therefore they have gone blind. So it's a kind of psychological explanation, symbolic representation of psychological conflict. More commonly, in terms of conversion symptoms, I mean, one of the common conversion symptom, relatively common conversion symptom, is pseudo-seizures and those are most common in people who have epilepsy. So people who actually have epilepsy, a certain percentage of those people will also have some seizures where they're not having an abnormality in the EEG at that time. So in effect, by their own experience or by being around other people who have seizures in the course of going to clinics or whatever, they've taken on board this model and it's now expressing being used to express or expressing distress. So in that sense, it's a representation of an illness model, not of a conflict per se. I mean, there may be a conflict behind it, a conflict over autonomy. I remember a client I worked with years ago who was having struggles over autonomy, and every time that she had a seizure, her mother, she would be rushed to the emergency room, and her mother would rush to the emergency room, and they'd all spend all this time. But when they examined her at the hospital, looking at the EEG and behavioral stuff, she was not having electrical seizures. She had some EEG abnormalities at other times, but she was not having these EEG seizures. But it served a big function to represent her anxieties over autonomy and to engage her mother in this and so on. Symptoms can also be a metaphor for experience. We have a lot of this in everyday parlance. Every language has a lot of metaphors. You're making me sick to my stomach. You're giving me a pain in the neck. This is just one big headache for me. We have similar things in most languages that draw from common bodily experiences to talk about everyday life, and it works the other way around in a sense. I'm going to say more about that in a moment. This idea that metaphor represents a kind of transaction between language and bodily experience, and that can work in two ways. We've already talked a little bit of the cultural idioms of distress last time at the beginning today, but I'm going to talk about this in more length in a moment. But this is the idea that bodily symptoms can be part of a language, a local language of suffering or explaining distress to people. And so focusing on them, talking about one's dilemmas around them can be a way of gaining sympathy and attention from other people. And then taking that a step further, it can be an act of positioning in a local world. That is, if I say, look, I'm really sorry, my back's hurting, I can't take out the garbage today, and my wife has to do it. So I'm gaining a certain local advantage of a very small type out of that illness. And finally, it can be a kind of form of protest or a social commentary. And now, each of these, and there's a lot of anthropological writing, other writing, sometimes some in family theory and family therapy sometimes, where people will talk about a person's symptoms being a form of protest. Now, what I should say is that each of these are possible. They're not mutually exclusive. The same symptom could function in many different ways. Many of them are very hard to prove, in a sense. How do you prove that a symptom is functioning this way? And it's a dilemma, of course. Someone brought up earlier the whole issue around agency. It's a very delicate issue to ascribe agency to people over somatic symptoms that they're experiencing as causing them suffering. So to say, well, this person's chronic pain and their pain complaints are really functioning to change the family dynamics and to communicate to their partner how bad they feel and so on. That may or may not be true. It may be plausible in certain situations, but when you make that interpretation to someone, you're doing a very powerful intervention, and you may really be undermining and sabotaging the person at that point. So I think the issue around these things is not simply are they true or not, but from a clinical point of view, it's also are they useful? Is interpreting the symptom in this way useful, and useful to who? Because in a clinical setting, often these things are used, and when you have a case formulation, they're all trotted out to show what a sophisticated formulation you could make, and you could argue that the use at that point is really for the clinician. It's to show, yes, look how clever we are, we can come up with a good explanation of what's going on. But the more basic question, and ethically important question is this useful to the patient? And certain things may be very helpful for us because we think, now I got a handle on it, now I know why nothing's working, now I know why this person's sick, et cetera, but it may get us nowhere with the patient. In fact, it may even be harmful to the patient. So I caution you, because I've been myself at many times in situations where I feel like what's really going on is we're shoring up the profession, we're strengthening our own authority, our own confidence, our own ability to live with our limitations and the fact that we can't solve everything. We see people who are suffering and we really don't know what to do for them, and they're really having a hard time. And instead of sort of accepting the limits of our understanding and our efficacy, we construct a very elaborate explanation as to why the person is the author of their own suffering. And I see that mostly as a way of just washing our hands and protecting ourselves, and really often of dubious truth value and ethically dubious in terms of its implication for the patient. So let me say a few more words about cultural idioms of distress. As I mentioned, I think this is a very useful idea coming from medical anthropology. Mark Nichter, who originally introduced this based on his work with Havik Brahmin women in South India where he saw people using a whole variety of strategies or experiences, ranging from physical symptoms to complaints about things, to actions like being silent or like burning the dinner or so on, as ways of communicating distress. And the idea that this came from a range of options that were available to people, and that rather than just viewing things as somatization or as some kind of having some kind of basis in psychosomatic process, that things could be understood in a communicative framework as part of a communication process. More recently, he wrote an essay talking about what happened, the first reference I have here, about what happened with this idea of cultural idioms of distress, in which he, to some degree, rued the whole idea, because this paper of his has been very widely cited. It's a very popular paper. It's had a lot of influence in medical anthropology, and he said he kind of regrets it, because this was not meant to be an absolutely clear, rigid idea that people could then operationalize and apply in a reliable way. He was trying to provide an antidote to a perspective that he felt was ignoring these communicative interactional processes. And what he wanted was just to open people's minds to thinking about the range of these things, rather than implying that an idiom of distress is such and such, and we can now count them up and describe them everywhere. So this is a caveat kind of that coming from the originator of this idea. He's a medical anthropologist who worked in a variety of areas, works, and hopefully will be here for our summer school in global mental health. But his early work was actually in psychiatry, working in a psychiatry ward as an anthropologist, ethnographer, and so on. If you look at the list that I showed you last time of the culture-bound syndromes in DSM and similar lists, you can find a bunch of these that, among other things, function as somatic idioms of distress. That may not be the only thing they are. Some of them may be syndromes, some of them may be explanations, but one thing they can be is a somatic idiom of distress. And the most familiar one, for me anyway, is nerves, because I have my grandmother was someone who used to complain of her nerves and having many symptoms related to that, so I had a lot of intimate experience. And I had a very important moment with her one day that led me into this area of somatization. You know, if you talk to anybody, any healthcare practitioner who works with a certain area, they work with alcoholism or they work with schizophrenia, there's usually some biographical reason why they have a special patience, a special concern, a special affinity for working with that problem. Because it's all challenging, and one person's enthusiastic topic is too difficult or boring or whatever to another person. So in my case, I got very involved with hypochondriasis and a lot of other things, and it has both personal meaning but also family meaning. And in this case, my grandmother used to complain a lot about a lot of different symptoms. And there was one moment when I said to her, you know, Bubby, the Yiddish term for grandmother, I have the feeling that no matter how much you suffer, no matter how much you try to tell us how you're suffering, no one really understands how much you're suffering. And she got tears in her eyes and she said, "You understand me." So I think when we're trying to understand this kind of, incessant and repetitive complaint, we need to understand this kind of existential predicament where this person feels, for whatever reasons, developmental, personality, the responses of other people, that they're not being heard. And so they have to keep going on and on. There's another story about this. Izzy Pawlowski, an Australian psychiatrist who was very involved with introducing ideas of illness behavior and abnormal illness behavior as a way of thinking about psychosomatic problems. One of his colleagues, Rob Barrett, described how when he was working with someone who had many somatic complaints, he would sit down very patiently and ask them about each one in great detail. And after they went through all the stuff about their headaches, and then they talked about all the stuff about their fatigue and all, and he'd say, "Is there anything else?" And he would just give them the sense that he was willing to sit there forever. And it was a profound experience for most of these patients, because they had worn out everybody else, right? Nobody else had any time for them. And particularly psychological practitioners who always had the attitude, well, let's get enough of this physical stuff. Tell me what the real problem is. Aren't you emotionally distressed? Or isn't your marriage a problem? Try to get to where the real action is. And by simply taking each of these somatic symptoms very, very seriously and going through each of them, eventually he would have great rapport with this person, and eventually, most often, they themselves spontaneously would mention other things, would mention emotional things, would mention relationship things, and so on. So there's this kind of process of feeling recognized, feeling understood in your primary experience, your bodily experience. And again, I think these are People who are suffering this way have probably have a lot of bodily distress in the first place, have probably had a lot of experiences of people not listening to them for a variety of reasons, and need this kind of empathic listening that does not shy away from the extent of their experience. Of course, this runs directly counter to the idea that somehow you're going to be reinforcing people's symptoms by listening to them. So these are countervailing forces that you have to think about at different moments in somebody's evolution. Arguably, it's after you've borne witness to all these symptoms that it may be possible to tell somebody, you know what, maybe talking less about this now will be helpful, and let's figure out how to do that. So we've got lots of examples here. Nerves is one of them. I'll mention some of these others as we go along. Let me take the example of Hua Byung for a moment. Hua Byung, which is a Korean, been described as a Korean culture-bound syndrome by Kemming Lin and others who did work on this. And Hua Byung means literally fire illness. And fire, as you may know, in Chinese medicine, Korean medicine, is one of the 5 elements, the 5 evolutive phases out of which everything is made, including the body, and imbalance of those elements can explain illness in traditional Chinese medicine. But each of these elements is not just a physical substance. It is a physical substance. It's also a kind of energy, and it also has manifestations at many levels, so it has emotions attached to it. And you might not be surprised to know that one of the emotions attached to fire is anger. That's probably a cultural universal. It has something to do, again, with the physiology of anger, that we get hot when we get angry. That's related to what the physiological processes of getting angry and the communicative value of it. But in Korean understandings then of this anger, one of the things that causes this anger is interpersonal injustice and feelings of indignation. So it not only is a word or an illness that alludes to the possibility that there may be anger in the background, but it also alludes to the idea that this may relate to an interpersonal situation of injustice. And in fact, there's writing suggesting that at a larger societal level, there have been cultural notions within Korea of a sense of collective injustice, what Koreans have suffered at the fate of the Japanese and others in the region, and this notion is called Han, the sense of collective injustice and indignation that people feel. So, on the one hand, Hua Byung is often felt as a burning in the epigastrium, that you have a burning feeling in the esophagus. But it also has this meaning of anger, it also has this meaning of interpersonal injustice. So if somebody comes complaining of burning in the epigastrium to a doctor here in Montreal, they're going to get gastroscoped to see, do you have peptic ulcer disease? Do you have gastroesophageal reflux? They'll get a prescription of antacids and an H2 blocker, and the assumption will be you have a physical problem. We know what category that fits in. To a Korean psychiatrist, incidentally, this is not, and the Korean psychiatrists I've spoken to do not view this as a culture-bound syndrome. They see this as a folk explanation related to Chinese medicine. And to somebody listening to this in that mode as a cultural idiom, you might well want to ask questions about relationships and about feelings of anger and injustice. Even though the person might not consciously be doing that, they were likely to think that all these things are related in some way. And they may be focusing on the element that's connected. So this is an example of something that has been framed as a culture-bound syndrome, might be more accurately understood as a kind of explanatory model based in culture, and that can also function as a cultural idiom. These are some examples of idioms that may be associated with depression. Teresa O'Neill did some work in the Flathead Reservation in the United States, looking at Vietnam veterans, American Indian Vietnam veterans coming back to the reservation who were going through many of the symptoms that we would view as being part of depression. But the typical way they talked about it was as loneliness. So this is a different language of distress. It would not, if you came and talked about loneliness to the average psychiatrist, they would probably not think about depression particularly. It would not be the first thing that would come to mind. One of the other things on here for China is, and here my accent or my inability to pronounce and speak these languages starts betraying itself, but anyway, Shenjing Shui Ro, which translates essentially as neurasthenia, nervous weakness. This was a common diagnosis until recently in China and many parts of Asia. Interestingly, it originated in the United States in the 1800s with the work of George Beard, a neurologist, who proposed the idea that certain kinds of problems of fatigue and enervation could be due to a depletion of nervous energy. So in the neurology of that time, this was a plausible kind of explanation. And this idea traveled globally, became a popular idea everywhere. And long after it had been given up on to a large extent in North America and other places, it persisted in China and Japan. And it was the most popular explanation for things that we would otherwise label as depression. And in fact, in the 1980s, Arthur Kleinman did a study in Hunan where he diagnosed a group of people who'd been or assessed a group of people who've been diagnosed with Shenjing Shui rule, and he applied DSM criteria and said that virtually all of them could be diagnosed with major depression. They fit major depression very well. And in fact, when you gave them antidepressants, as he was able to do in the study, many of them got significantly better in some of their symptoms. But most of them did not feel that they were cured. They still had Shenjing Shui rule. And the reason is that they had other symptoms and other understandings of the nature of their suffering that were not encompassed in the template of depression. And in particular, the nervous weakness that they saw, many of them related to terrible trials and privations that they had had during the Cultural Revolution, in which they had suffered greatly, you know, the terrible cataclysm in the whole society, with really many profoundly tragic stories. And talking about the impact of those events, not in terms of the injustice of those things, which was very difficult, very politically loaded, dangerous thing to talk about, but talking about your own state of depletion, of being broken down, of what had damaged your nerves, was a relatively safer way to talk about this kind of suffering. And that problem was not resolved by giving people antidepressants. So it points out also how you can have this illness category, disease category, let's say, of depression. You can recognize it even in a very different cultural context, but it's being expressed through other idioms, and the idioms have a life of their own. They're not totally subsumed by. So even though you could say, okay, these things map onto depression to some degree, they map onto other things also. There's not a one-to-one mapping at all, and they have their own implications, because they're also languages of suffering, and of suffering that may be larger than any particular disorder that you might be able to identify in a person. Let me see if there's another example we should pick here. Well, I'm going to talk about Feng Tap and Wat Wook in just a moment. And most of these things that you see here are, I think you have this paper and you're reading this chapter, and you have readings and you have some other things. So you've got descriptions of all these things if you're curious and you want to pursue some of them. So here's another interesting take on these issues and the relationship between a disorder and an idiom and how these things might play out. So this is data from looking at symptoms of depression in Africa and Nigeria. It's a large survey with many people, and these are it's using a checklist of depressive symptoms, but supplemented with other symptoms that may be common in this African setting. And this is just, first of all, a sort of series of factors that are taken out by factor analysis. So what that means is that you're looking at the way groups of symptoms cluster together, hang together. People who report one of these symptoms tend to report other ones if they have a high loading on the same factor. So here you see loss of weight, feeling down, depressed, or hopeless, feeling bad about self as if a failure, sleep unsatisfactory, excessive bad dreams, poor appetite or overeating. So most of these things are viewed as core symptoms, not the last few, but as core symptoms. Well, I shouldn't say that. Loss of interest or pleasure is absolutely a core symptom of depression. These are, okay, this is a better way to show it here. These are several factors here. We've got 5 factors. And the first factor is got this, what has it got here? It has weight loss, hands and body, let's just take the high loadings here, because they're not all high loadings anyway. So weight loss, in fact, that's the only thing that's really high on the first factor here. The next one has emptiness in head, fainting spells, fluid inside head, crawling sensation in head. These are not common symptoms you would find in North America. In fact, in North America, if you walk into an emergency room and tell the doctor, I have a crawling sensation inside my head, you're in trouble. I mean, unless they think, okay, maybe if you're taking cocaine and you're having like formication sensations where you get a kind of creepy, crawly feeling in your skin or whatever. Otherwise, the attitude is going to be, this is a kind of bizarre symptom here. Maybe we should be thinking about psychotic illness. In Africa, feelings of worms crawling in the head is a very common feeling. Feeling a peppery feeling in the head, very common non-specific symptoms that people report in equatorial regions. So we've got a whole bunch of somatic symptoms here on factor 2. Factor 3, you've got a bunch of pain symptoms. And factor 4, you have heart beating fast, peppery feelings, nausea, and so on. And there's, if you put together, I guess they did various kinds of analyses. Here is a loading where you're comparing the cognitive symptom loadings, and they all load on factor 4 here. And what you've got is difficulty in remembering, slowed mental operation, difficulty in comprehension, inability to read for long, trouble concentrating on activities such as reading or watching television. Now, if you look in the DSM around depression, you'll see that trouble concentrating is an important symptom of depression. In Nigeria in the 1940s, Ray Prince, who my predecessor as head of Division of Social and Transcultural Psychiatry at McGill, was a government psychiatrist working in Nigeria and working with students, and he described a culture-bound syndrome of brain fag. Brain fag in Nigerian British English, fag means tired, and so brain fag was basically tired brain. And this was described among young students who were coming from rural villages to the university, to the big city. They're often the first in their families and their communities to become literate. They were coming from small villages, and were experiencing a lot of stress and strain associated with studying. And then they would complain that I've been studying very, very hard, and my head's overheating, and I can't concentrate, and my brain is really fagged out. And it would be very distressing because then they would feel they couldn't study, and it was really a very frightening experience. So he described this as a Nigerian culture-bound syndrome. And generations of African psychiatrists since then have worked with this concept. They have measures of it, and this comes out of amalgamating some different symptom measures and showing that, lo and behold, you can find this dimension in the expressions of distress of people with depression. However, brain fag is not only associated with depression, it's also associated with anxiety, it's also associated with money worries, and no psychiatric disorder, but just being very worried about your money or worried whether you're going to fail in your exams or all kinds of other troubles. So in that sense, it functions both as a syndrome and as an idiom of distress and has other meaning. And here you can see, I think, is this the one I wanted to show you? I guess this is the symptoms that distinguish between the presence of depression or not in a logistic regression are these core symptoms that are, in a sense, universal, that we would find also in North America. And these other symptoms are much less specific. So they're operating, they may be the main ones people talk about initially, but they don't hang together in quite the same way. So this speaks to the issue, discussion I already had in relation to ataques de nervios about how are we going to understand the relationship between this huge cultural variation in symptoms and what is discernible as a pattern across cultures. Now, it turns out if you take this same some of these same questions. For example, years ago, David Mumford developed a somatic symptom questionnaire based on the symptoms reported to doctors in Pakistan. Because most of the symptom measures we have come, again, from the West. They come from a very narrow segment of people. So the symptoms that we think are important come out of those studies. So he went to medical charts in Pakistan. He started listing what are all the symptoms being listed. And he came up with a list of about 42, 46 symptoms. It's called the Bradford Symptom Inventory. And it included some symptoms like feelings of butterflies in the stomach, feeling of heat in the head, a bunch of other things that are common, again, in these cultural and geographical regions, because the issue of heat in the head it's an equatorial phenomenon all around the world. People who live in hot climates are more likely to report heat in the head for some fairly simplistic reasons. But anyway, it becomes a symptom, and it fits with local ideas about hot-cold types of illness, because then you think, oh, this heat in the head might mean that I'm overheating, and that's a whole set of illnesses, and a set of treatments are implied, and so on. So what he did was he took this questionnaire at one point and he gave it to British medical students. Now, a bunch of those students actually were from Pakistan, Britain, and everywhere else being what they are these days, but a lot of them were not. And what he found was that the non-Asian British medical students also reported heat in the head when you asked them point blank. So it raises this interesting issue related to what I was saying before. Whether we report things or not, whether the culture makes them significant or not, does not necessarily determine whether they're happening or not. There are things happening all the time for all of us that we don't think about, we don't talk about, we don't have a category for, nobody else thinks they're important. Unless they get very, very severe, they just sort of are below the radar, as it were. And you can ask people point blank, well, what about so-and-so? And people will check it out and say, well, yeah, actually, I have had that feeling. Just didn't think much of it. In North America, Montreal, if you have heat in the head, I mean, basically it means you have a fever, or you have a menopausal hot flush, or you've just been running like a demon up the hill. I mean, I think those are about the three main categories that you can get away with. It doesn't have a lot of other meanings for people. So, even though it may well occur in other times, it certainly does occur with any kind of flushing or whatever, a little bit. So we're probably having feelings of heat in the head a lot all the time as our vasculature does whatever it does, but it's not salient culturally. So I think that's a generally interesting issue about phenomenology and about the cultural shaping of phenomenology. Okay, a couple more things. So I've mentioned already this notion of that in many parts of the world, people's understanding of what bodily symptoms are related to is not so much in relation to mental distress, but in relation to social troubles. And this has to do with the fact that this inner theater of the mind, which is so highly privileged and which we're so fascinated by in the West, is not where the action is for people in many other traditions. Not all. I would say traditions like Buddhist societies and traditions where there are technologies of the mind that are important will give importance to that inner theater. But in general, in many societies, people are focused on things like interpersonal relationships or on a spirit realm or some other place than just what is happening inside their head in terms of what they view as socially important to talk about. And in those contexts, people often have sociosomatic theories, things that connect things being out of order in the social world and ill health. This is a term that Arthur Kleinman introduced to argue for not only for a better understanding of the experience in certain cultural contexts, but in our own theorizing on how we think about that. So I'll give you an example of sociosomatic theory in relation to some work that Danielle Groslo and I did some years ago looking at Vietnamese here in Montreal. I mentioned this big survey at one point that we did on help seeking. Part of that survey was asking people whether they had these medically unexplained symptoms. Some of those people who have medically unexplained symptoms, we went from a survey to doing very intensive interviews with them. And tomorrow, again, I'll talk about the methodology for that. And so we got these very long interviews of several hours with people about their physical symptoms and what they meant. And in the Vietnamese sample, we interviewed about 20, 25 people from Vietnam. And a bunch of those people, 6 or 7 of them, reported something they called phong tap. Phong tap translates essentially as rheumatism. It's pain in the joints. Again, human beings everywhere, very common problem, more common as you get older, almost inevitable as you get older, and so it's not surprisingly there's a term for this. The Vietnamese understanding of this is this happens for a variety of reasons, aging is part of it, but also exposure to cold winds can cause this. And by winds, I don't literally mean winds, although that's related, but a kind of energy, a kind of force in the world, right? Just like this idea, I talked earlier about the idea of fire in Chinese medicine. So these medical systems have notions of these energies or elements that make up the world that can manifest in many different ways, and these can give rise to illness. So cold winds can give rise to phong tap. And there are particular times when people are vulnerable to phong tap. So for example, women, immediately after giving birth, the body is considered very open, all the pores are very open, and you're at risk for a cold wind at that point. So ordinarily in Vietnam, when you have a baby, a midwife will be there and she will prepare special materials and some herbs and some steam coming from those herbs, and that will help to close your pores and prevent you from getting a cold wind. If you don't have that, then you might get a cold wind, and years later you might develop phong tap as a result of that. So that's an interesting explanation. In other work that Danielle did, it turned out that this kind of process was very significant for people migrating, because when you migrate, maybe the midwives don't come with you, and maybe you're now in a whole new healthcare system where you're supposed to give birth in a different way and deal with everything else, and you don't even have this knowledge anyway. You know vaguely that these things are supposed to be done, but this is a kind of expertise that the midwife would have, not that you would have as a young woman. So you know something's amiss, but you don't know precisely what, and you could not even give maybe a clear account to a doctor, but if you talk to enough people, you begin to understand what the configuration is supposed to be. When we talk even more to these people with phong tap, Meaning in the course of this long interview, as trust was built up, as they told their story, retold their story, they started adding other elements. So another thing that they brought up, some of these people, was that, well, another thing that causes Phong Top is this coldness of the Canadian climate, that this is a cold place if you're coming from Southeast Asia, and that was aggravated by the emotional coldness that they had been through, because what had happened in many cases, they migrated as a nuclear family, and then their kids went off to Toronto to start their lives, and so they were living for the first time in households where it was just an older person living alone or living with just a few people, as opposed to the extended family that they'd had. So there's another layer now of social isolation, and this is where Phong Top starts becoming an idiom of distress. The same as my grandmother would have talked about her aching joints, and she is literally talking about her aching joints, but she's also talking about loneliness, about unhappiness, about other things, for many reasons. Partly because, of course, if you were in a lively, happy situation, maybe you wouldn't notice your aching joints so much. But also, talking about your aching joints is a way to let other people know, without putting too fine a point on it, that you're unhappy, that you're lonely, that you're miserable. Another layer that came out for some of these people was they were, in many cases, refugees, had come as refugees to Canada as part of the sort of boat people who'd had a very, very difficult migration from Vietnam, spent time on boats literally in the South China Seas and facing pirates and so on. And they started talking about horrible traumatic events that had happened, that they'd been on a boat, that pirates had attacked, that they'd thrown people overboard, that they'd seen people killed in front of them. And this was related to their Phong Top. So with a long enough conversation, we started getting some traumatic stories too. Now, does that mean the traumatic story is the real story? I don't think so. I think it's another layer. I mean, any one of these stories is good enough to explain some of the meaning of Phong Top for them. But it just means that it was another layer of narrating, of trusting, of deciding to explore something because of that situation. That was one idiom of distress. Another thing that people brought up, though, that speaks more directly to this idea of sociosomatic theory was some people mentioned that their unexplained symptoms were due to wat wook. And these could be a variety of symptoms. These were not limited to musculoskeletal symptoms. And wat wook translates, if you go to sort of Vietnamese English dictionary, what you get basically is indignation. And this is illness due to a sense of injustice, that something has happened to you that has really humiliated you or created a sense of anger at injustice, but you cannot talk about it. Because you're coming from a hierarchical society, a Confucian society in which you have to respect the hierarchy. You would be a bad person if you don't respect the hierarchy. It's you who will be deficient if you show that you don't respect the hierarchy. So you have to swallow whatever happened to you. And as it was explained to Danielle, who's doing some of these interviews, one of the people interviewing it told her, you wouldn't understand this because it's a more sophisticated idea than you have here in Canada. But if a person has this kind of humiliation, then it can sort of fester inside them and give rise to all kinds of illness, to heart attacks, to all kinds of physical illness. So this is explicitly sociosomatic theory, because the notion is this injustice has happened and it's going to have bad effects and you will have this physical illness. In fact, the story one person told was related to a kind of humiliation, a kind of love affair, failed love affair with someone who was her superior, and she could not talk about it, and it went on. Now, wat wook is not, it's a sociosomatic theory, it's a causal theory. It's not an idiom of distress because you can't actually talk about wat wook to other people, about yourself, because it would point to exactly the thing you're not supposed to be talking about. It's the shameful story or the destabilizing story that you have about the hierarchy that you're supposed to be helping to maintain, not challenging. And so what happened in these situations, because the interviewer was an outsider, people would tell the story eventually and then sometimes spontaneously say, you know, this is the first time I've ever told anybody this story. And I can only tell it to you because you're not part of my community. And interestingly, in anticipating our discussions later in this course around psychotherapy, some of these people said, I feel really, really relieved having told you this. So interesting issue about what may be forbidden to speak about and what may actually be beneficial to speak about in the right, safe context to the right person. Because it doesn't mean, having spoken about it, doesn't mean you can now go back and say, great, now I can talk to everybody about this. It still is a loaded situation that would be destabilizing and cause trouble for other people and trouble for you and so on. So you still have to manage it somehow. Okay. So the last thing I want to talk about, I think it's the last, I hope it's the last thing. We're still on track here. So The last thing I want to talk about is a broader notion that has been central in medical anthropology for some time, of thinking about the embodiment of experience. Embodiment is a term that has been borrowed and used, directly applied from phenomenology, and the notion that there are experiences that are fundamentally in and of the body, and that we need to understand them that way. And partly this became extremely popular in the 70s and 80s and into the 90s, partly because of actually a bit later than that, say 80s and 90s, because of a neglect of the body in the social sciences and in anthropology. There was so much emphasis on what can be reported verbally, on language, and on the cognitive. And people started feeling like, you know what, this is getting very skewed. If you actually look at how people experience illness and suffering, it is very bodily. And we need a language for that. And that's not only an effect or a consequence, it is in many ways the origin. It's the sort of ground out of which these things are emerging. So the question is how to understand this, how to approach this. And there is a rich literature from phenomenology, Merleau-Ponty and others, particularly Maurice Merleau-Ponty, trying to talk about bodily processes from an introspective point of view, using a phenomenological method to try to describe these things. And that got pushed aside in psychiatry. As I mentioned last time, that phenomenology with DSM-3 became not experience but symptom checklists. So we're not interested in the texture of your experience now and how one hallucination might differ from another, or whether you might feel this thing in your body or not, but really just, do you have this, are you hearing voices or not? That's it. That's all I need to know, and now that's all the information I need. As opposed to what happens in phenomenological philosophy, which is a much more fine-grained description of experience, with an effort then to describe in more abstract ways what are the dimensions and the parameters of experience. So this has been an important move within medical anthropology, and I've cited here a couple of the key early papers, and then my own intervention in this, which I'm going to explain in a few moments. So what I want to do now is tell you a little bit about this idea of cultural phenomenology. How is it that, because in phenomenological philosophy, there's kind of an assumption that, again, that all human beings are essentially similar. Therefore, any one of us can look inside and find out everything we need to know about human beings, if we're sufficiently observant and clever. And so if I'm a German white male of a certain age and time period, I can write about universal phenomenology, or at least get close to that. Versus the idea that, well, maybe all experience, no matter how intimate and no matter how fundamental, is always culturally framed and culturally inflected, which I would argue for, and which I think demands then explicitly cultural phenomenology. And then I'll say a few words about neurophenomenology, the idea that there might be traces of the body and of the nervous system in our phenomenological experience, and then the question of how to put these together. So here's an example of cultural phenomenology from Japan. These are words about emotion that embody emotion. So one of the key words in thinking about feeling in Japan is kokoro. Kokoro is like the center of feelings. Kokoro is like a heart-mind. Kokoro is here, and this is where feelings occur. So again, you can see some universal elements. Many societies understand the heart as a center of feeling, and the reason for that, again, is because the heart's very reactive to feelings. If you're anxious, if you're angry, if you're sad, you definitely feel sensations here in the body. There are many, years ago, Byron Good and Mary Jo Good worked in Iran and described Narhatya Galb feeling of heaviness in the heart. And this is a very common idiom throughout that region of the world. And people feel this as a physical sensation in the body, and it's associated with grief and sadness and so on. So there's an understanding this is where you feel these kinds of things. So you have this idea in Japan. You also have the notion that you have another center of feeling, which is the hara, which is over here, just the solar plexus. And most of the Japanese, and then thinking is atama, and that has become more important with Western influence. And there are a lot then of cultural idioms to talk about emotion that reference kokoro and or hara. If you want to say somebody is upright and courageous, and you say haragatatsu, their hara is standing up. So, you can see the analogies. I think I have a bunch of idioms here. Okay. Harakiri, which is not the the correct term. That's the crude term for it. Seppuku is the formal term for this ritual disemboweling. And yes, it's cutting the hara. That's where you cut. And the reason you're cutting a center, a feeling, a vital essence. What circulates in the body, in the hara and so on, is this energy ki, or chi, in Japanese ki. And ki is, again, the breath is ki. It's a kind of movement of the spirit from moment to moment. And there are a lot of idioms around ki. So you can have, your ki is blocked, your ki is heavy, your ki is leaking. So these are all part of cultural phenomenology. We can see analogies. You can get inklings. It's not totally foreign. When you hear this stuff even for the first time, each of us can probably in our own language or own background say, yeah, I have an inkling of what they're talking about. But the specifics are quite different, quite unique. And if you try to take a very specific English idiom and translate it, people will not understand right away. They will see it differently. I'll give you another example. In Japan, a lot of metaphors of the body and of illness are plant metaphors. Human beings are vegetation, are vegetable, or like bamboo, or like other vegetation. In English, if you analogize somebody to a vegetable, it's not at all a compliment. It just doesn't work very well. But in Japan, in Japanese, it works quite well. So there's a whole domain that's coming into play with a lot of images that are conveying this meaning. So this is part of what I mean by a cultural phenomenology in which there's an intimate interplay between particular languages, particular imagery that has a long history, a long cultural history, and that people are using to explain and to articulate suffering, and that then get sedimented and embedded in everyday language, because these expressions I showed you earlier, in a sense, these are literal expressions. They're not viewed as, you're not being poetic now. This is just how you say this. This is just how you say that you have such and such feeling. You see, it's not that you're making a big theoretical statement or that you've come up with a poetic thing. It's just how you say it. So, but there was a history, there was a point at which in somebody's creative language this was a poetic moment, and it followed from a certain kind of experience, and now, hundreds and thousands of years later, it's just part of how you say things. So, and we need to remember this, of course, because the language I'm using right now with you all the time is full of that, right? But that's just the language we're using, and we forget that that's where it all came from. So behind this are ethnophysiological theories of how the body works, of what the body is made up of, the kind of structure of the body, of the energies that flow in the body. So these are images from the central one from Chinese, the other ones from of acupuncture meridians and flows. So that's what I'm going to say for the moment about this idea of cultural phenomenology. I'm going to come back to it in a moment. I want to talk about the other pole now, because what I've just said implies in a way that this is very malleable and we all have different histories. And if you look, for example, in Indian languages and Sanskrit, there's a whole vocabulary of emotion, and the dominant word for all this is rasa, which is taste. And so you have a whole vocabulary around different kinds of tastes for talking about emotions. That has a long history, and it's elaborated in the arts and so on. So you can trace this whole thing, and to do a good job of it, to understand what it is, you have to do a whole elaborate cultural history of how these things, how different people talked about them, how are they used, and how do they now occur in everyday language for people. And the implication is a kind of huge variety, even though we can see common elements, as I say, that if you look for what role does heat play in people's systems, among other things, it will almost always be connected in part to anger, but not only, and not the only meaning. You'll find some of these things, but not that much. So that commonality brings us back to this idea of neurophenomenology. So this image is here to help us think about the idea of neurophenomenology. This is a moire pattern. And the reference you see here is Heinrich Kluwer, Mescal, and the Mechanisms of Hallucination. This is an image similar, I think it's a similar image like this on the cover of that book, I think. If you close your eyes now and press on your eyeballs gently, not too hard, please. I don't want to be responsible for anybody bruising their eyes, but you press lightly on your eyes and you wait a few moments, you will begin to see a moire pattern. You'll begin to see checkerboards. So what are you seeing? Where is that structure coming from? This is a very crude stimulus you're putting on your eye. It's just pressure. And what you're seeing is some of the structure of the first few layers of your visual system. So this is a kind of neurophenomenology, right? There's a structure coming out of, here's a crude stimulus, just pressure. And what you're seeing now is a structure. Where's the structure coming from? It's the structure of your nervous system, in a sense. In fact, interestingly enough, if you stop it and then do it a second time, you get a slightly different moire, and I forget which is which. One tends to be circular, one tends to be more vertical checkerboard. So there's a kind of effect, again, and this is related probably, I don't know, probably related to lateral inhibition or something like this. I don't know the details of it, but it's an interesting example of a kind of proto-structure that's there, just given, it's like hitting a tuning fork, and now you're getting a kind of particular kind of, in this case, set of visual frequencies. So that's a crude kind of neurophenomenology. Here's a slightly more elaborate kind of neurophenomenology. This is a famous painting called The Nightmare, and this is an image of this kind of monster sitting on this woman's chest. You see the horse, the mare, in the background, and this can be understood as an image of a kind of experience, in this case, of sleep paralysis. I think we might have mentioned this a bit in the first lecture, this notion that there's a phenomenon where you can wake up in the middle of the night and you are paralyzed, and you then, but you're awake, and so then you have this very unusual experience. And I did talk about this a bit last time. So the point is that there again, there's a neurological structure to this experience of being awake yet being paralyzed. It's given to you by the body. It's a very powerful set of experiences. But what happens from the first moment that you have this experience is you begin to try to interpret this, to make sense of this, to the extent that you're conscious. In fact, even if you're not conscious, even if you're dreaming, your brain is also trying to make sense and make patterns and so on. That's what's accounting for the dream story. So you have this kind of circular process, not totally dissimilar to what I was showing earlier around somatic symptoms, in which you're trying to make sense of this bodily experience. So you have a kind of elaboration of this neurophenomenology. So we have, on the one hand, cultural phenomenology, cultural shaping experience. On the other hand, neurophenomenology, the body shaping experience, and then the reality of any actual experience of these two things interacting and producing experience. How to think about this. So this is my last set of slides for today. You guys this is where you have to draw on your last reserves of energy here to stay with me. This is where we should have stopped half an hour ago, but anyway, we're going to push on just to make this last point. I think a particularly powerful, useful way of understanding the interplay between the cultural phenomena and the bodily phenomena is through metaphor. And I mean that not by using metaphors, but I mean by understanding the nature of metaphor itself, because we now have a significant amount of work coming from cognitive science trying to understand how do metaphors work, what's going on with metaphors. And we have a convergence, in fact, I say cognitive science because of a convergence between cognitive psychology, philosophy, neuroscience. A lot of different disciplines have been very, very interested for the last 20 or 30 years on metaphor and trying to do basic work on understanding how metaphors work. And one of the consequences of this is to show, one of the early things coming from George Lakoff's work, is to show that metaphors are completely ubiquitous, that language is full, every language is full of metaphors. And in fact, that's how language is built. It's built from a simple vocabulary of bodily experiences into more and more elaborate language based on metaphors. So it's almost impossible to make any kind of a sentence, complex sentence, without using all kinds of metaphors. And those metaphors, as I say, if you start tracing them back developmentally, they come back to very basic bodily experiences. So, for example, well, when I say come back, what am I saying? I'm saying something has gone out and now it's physically coming back. When I say based, what do I mean? Well, I mean something is put on top of something else. And so, as I say, it's impossible to say anything abstract. It's impossible to say anything of any richness without employing all of these metaphors. The metaphors are built on a kind of scaffolding so that more complex metaphors are based on earlier metaphors, and they sort of have a whole history. And what happens over time is they go from being novel metaphors. A poet makes a fresh metaphor, and we say, wow, I never thought of that way. And we're excited by it. But when certain things get taken up into the language, the lip of this cup is just the lip of this cup. It's not a lip anymore. But that's how it got to be the lip of this cup. So what's interesting to me is not only are all these things, these dead metaphors, like with the lip of the cup, that's just the literal name for the cup. But what's interesting is as soon as I tell you this, it's very easy to reactivate the metaphor. So what's fascinating to me is that our language is made up entirely of dead metaphors. We ordinarily don't worry about it at all. We process them as literal, and yet it just takes a split second, a Walt Disney movie or anything else, for the metaphor to come alive, and we're amused, and we're engaged, and we're enlivened, and we're thinking in new ways. So there's a clue there, something very important there about phenomenology and about the liveness of language and about the connection between body and language. Because on the one hand, let's see if I segue to my slide, on the one hand, where these metaphors came from, to some extent, is from this phenomenological neurology of embodiment, from these bodily experiences of what it is to have a lip and what a lip is like and what goes through lips and all this other stuff that we've had starting from infancy. So there's a source. Other things feed into it, of course, because we have cultural shaping. So once you have lips of some kind and they're appearing somewhere, it has other meanings, and those meanings are now also going into that metaphor. So it's not just, it may developmentally have come from this simple bodily experience, but it gets other stuff layered onto it very quickly, and that becomes part of it too. And then the metaphor itself is used to think about other things. So this is going on constantly. And because it's possible to bring things back alive again, things can flow in both directions. Developmentally and historically, things came from these bodily experiences. They became our everyday language, and it became more and more abstract and more fixed in a way. And so we don't think of it anymore as metaphors. We just think of that's the abstract technical term for this kind of thing. But we can easily reactivate it, and when we reactivate a bodily experience, because the other thing that we're learning is that cognition is embodied, right? To think, we use our bodies. So, for example, I think I may have mentioned this last time. Well, in fact, I can show you in these next examples. So here's some examples of how these things are connected. We have in every culture notions about posture, about bodily stance. I mentioned already the Japanese metaphor haragatatsu, of your hara standing up, right? Standing up like this, right, in every culture is different than being like this, right? One is a state of dejection and depletion, and one is a state of energy and vitality. And you don't need to know anything about a specific culture. If I told you one is which one is the other, I think you could go around the world with everybody, and they would, just like this famous, this famous example from Wolfgang Kohler. This famous example from Wolfgang Kohler, probably all of you have seen this. One of those is called Taketa, and the other one's called Maluma. Can you tell me which is which? Which one is Taketa, and which one is Maluma? Okay, so what are you doing and making? I mean, human beings everywhere in the world can do this. They don't need to know the language this came from. It doesn't come from any language, as it turns out. But anyway, and what you're doing is you're doing a cross-modal analogy or a cross-modal metaphoric mapping. Taketa, okay, auditorially has the same kind of sharp changes that one has, and Maluma auditorially has the other kinds of shapes. So that's a bodily thing. That's a phenomenological thing, right? That's what poets work with, among other things. Why poets will say, contra Ferdinand Saussure, that the relationship between words and meaning is not arbitrary, right? The structural linguists argued that it's arbitrary. Any sign can be attached to any sound. No poet in the world would ever agree with that. They feel, no, it's absolutely it's necessary. It has to be this word because of my bodily experience and where this language came from. Part of that, of course, may be idiosyncratic bodily experience. We all grow up in different environments. We have different tastes, different sights, different sounds, but our language is rooted in those experiences. So I'm using the metaphor of stance. Now I've shown you something about stance. All around the world, language of stance has meaning. It has moral meaning. It has meanings around anger, around confrontation, around social status. To lower yourself before something is to show respect for that, right? Many religions have prostrations as a way of expressing relationship to the divine, to something transcendent. So I'm arguing there's a bodily logic to this, that this is not purely coming from the top down from some very abstract notion, but really coming from the ground up. But it works both ways. Here's a woman wearing a traditional kimono, and she's wearing the sash around her which covers the hara. Right? That's why that's there, to protect the hara. Bodily posture communicates things to us right away. So here's another image of loss from William Blake, his character LOS, loss, in agony. Right? And this bodily posture conveys to us fear, horror, pain. I mean, we get that sense of somebody being torn down right away. So my point is that the language of stance is not arbitrary. It's bodily rooted, but it's used culturally in all kinds of ways, and then things flow in both directions. If you're asked to do a prostration, you feel differently doing that prostration. It's a profound experience to do a prostration. Right? To lie on the ground before someone else or before an image or something is a very powerful experience. And something is changing in you at that moment. You're feeling things differently because you're doing it differently. Even to talk about it, because we're symbolic beings. You don't have to do it. If I start talking about it, if I ask you to imagine it, you're going to start feeling things in relationship to that. And of course, it happens in everyday language. If you say, well, he really prostrated himself before his boss. Well, you have a visceral response to that, right? It's not just that, oh, he adopted the appropriate situation vis-a-vis his boss. No, he really humbled himself, and then it's going to have all kinds of implications for you based on your social code and how you view hierarchy and so on. So this is what I mean by things flowing both ways. I'm going to show you two other examples. Face. One other point about this, about stance. A big, significant portion of our nervous system is devoted to managing the issue of stance because we are two-legged beings who are always at risk of falling. Right? I mean, to stand is a constant active process. When you're standing, you're constantly adjusting your muscles to stay upright. Otherwise, you'd be flat on your face in no time. And what's interesting about that is if you give people a questionnaire to fill out with blanks in it, if they're standing with certain kinds of sentences, you can show, Raymond Gibbs' study, you can show that people will fill in those blanks with words related to balance if they're standing, much more likely than if they're sitting. So the whole notion of balance, which we see in healthcare systems and so on, and so on, is rooted in this bodily experience. And the importance of, why is balance important? Well, it's important because we literally are doing it all the time. You know, and we would be on our faces if it wasn't. Okay, so that's what I want to say about stance. Face. So face is very important. Faces are very important. Faces are how you recognize the individuality of each person and how you recognize what they're feeling and where they're looking, what they're interested in, by where their eyes are pointing and so on. So a big chunk of our brain is devoted to processing faces. In fact, separate parts of the brain associated with figuring out whose face this is and what is this face looking at, or what is it doing, or what emotion is expressing. These things can become dissociated. I don't know if I mentioned that the other day. You have things like Capgras syndrome where someone will say, well, you look like my sister, but I know you're not my sister. I can feel you're not my sister. So you'll have facial recognition, but not the feeling of familiarity, for example. So you can dissociate these things. Okay, so a big chunk of the brain is devoted to face. Face is very important. Metaphors of face are extraordinarily important around the world, and typically they're metaphors about social relationships and about social standing. Many Asian cultures have literally used the metaphor face and say it's very important to maintain face, to have good face. How are you seen by others? How do you present yourself to others? So again, I'm arguing this is a natural metaphor. It's through our face that we present ourselves to each other, and it can work both ways. So here's a Maori face. This is a warrior culture in which making fearsome faces is an art form at this point. I mean, at one time it was the thing you carried into battle, but it's been refined into a whole art, and you make these terrifying faces that, again, have this dramatic impact of taking a stance with others. And the face, more than anything, of course, is what gives us a feeling of the presence. Face and voice are the ways we feel the presence of another person. So here you see these children in Bali, and I think, again, for most human beings, this evokes a very powerful response of caretaking and concern and so on in these children's expressions. And finally, another domain of rich source of metaphors and a way in which cultures are working with metaphors and imposing new structures, our experience of time. Experience of time is embodied, right? Whether we feel that time is going quickly or slowly has to do with how we're present in the moment, how engaged we are, and how we're processing information, but we feel it and experience it very much as a bodily phenomenon. And many cultural situations try to modify time. Most artistic performance is related with playing with time in a way so that you're moved into a kind of mythic time, where you're told a story where, and all the myth cycles, what distinguishes a myth from a sort of popular drama is you know already what the end of the myth is going to be. It's a timeless thing. It's a cycle. You know kind of what's going to happen. It all fits together in a way. So in a sense, at any moment in the myth, you're apprehending the whole pattern. So you're in this kind of mythic time, this timeless time, and that can be modified by our own bodily stance and position. If you sit still and just watch what's happening, you initially will probably experience a feeling of great restlessness and of time dragging, and eventually you can experience a feeling of time falling back and of timelessness and of having spaciousness. And that's what happens in meditation, among other things, that then teaches you something about our own sense of the urgency of time, of the press of time, and so on, where that comes from. So I'm arguing that all these ideas that we have, some of which seem very abstract, some of which seem to be coming only from the top down, are also bodily grounded, and that the language we use about these in everyday life moves back and forth between these social levels of discursive description and embodied experience, and that each can engender the other. The body can be a source of fresh metaphors, and taking on these metaphors, thinking with them, changes how we feel in our body. You know, if I start talking to you enough about timeless time, you will get spaced out, I guarantee it. Okay. I think we're going to have to stop here. This is just, let me see what I have left here, I'm not sure. This is just an image of a body with the cosmos mapped onto the body. And a fundamental idea in many ethno-medical systems is there's a correspondence between the body and the larger world. And that's behind, again, some of the socio-somatic theories, is the idea that if the social world is in order, if the spiritual world is in order, the body will be in order, and vice versa. That there's a kind of correspondence between these two. And so you have systems of diagnosis that use astrological notions or use other things because of the idea that these are somehow in resonance, they're somehow connected and moving in parallel in some ways. And so this leads to different ethno-medical systems. And thankfully, we've reached the end of our talk.